think we know these drug-eluting stents will create some neo-intima, even though they are not completely opposed to the aneurysm. So I think if they don't have the option for this drug-coating balloon, then now is whether we do drug-eluting stent or drug-coated stent, right?
Right. So when we were trying to deliver stents, I'm just trying to show you this very annoying picture on the screen of the guide liner. And after that, we realized that it's not actually as easy, the angles and the stenosis, to deliver anything beyond it. So we actually, as you see here, this is live. We've upgraded to 7 French AL guide. So we're going to go with the recommendation of the panel. I believe you're recommending cutting balloon at this time. And then we proceed with either drug-coated balloon or drug-eluting stent.
Yes.
Nov, what do you think? You want us to proceed with cutting?
Sure, I think that's reasonable. We'll give it a go here.
So we'll start the 3-0 cutting, possible. So we'll start with the 3-0 cutting balloon, although it's likely undersized. You want us to start with 3-5?
Yes.
Okay, start with 3-5. So we pre-dilated that segment with a 3-0 balloon, and now we're taking a 3-5 cutting balloon. I'm hoping this guide is going to give us a little better support. If
Maybe
not, we probably
3-5
need
is
to
a
use an
larger
extension.
balloon.
I'm sorry?
I think 3-5 is a larger balloon. Better go with a 3.
So you'd rather use a smaller one?
Yes. And as such,
let's
the
get a
vessel
3-0
is
then.
a ectatic vessel, and we are trying with a cutting balloon. Better go with an undersized balloon.
3-0?
What would be a strategy for the stent? You have multiple sizes in this artery. You have 5 millimeters in some areas, 3.5 in some areas, and 3 in some areas. So, would you?
The modern stents, I mean, if you look at some of the Nagomi stents from Terumo, they can expand up to 6. So likewise, the Megatron and the Onyx, they can go up to 5.5. So I think we'll be safe to use one of these stents and then use a shorter post-dilatation balloon, shorter post-dilatation balloon to take us aside for optimization.
So is that a 3-0 Wolverine?
No, this is a Wolverine, correct. Ready for test? So this guide gave us much better support, and we're testing. So are you happy with this segment?
Yeah, I think it looks better. I think the support is better.
Right, going up. We're at 6.
So this is cutting balloon fully inflated at nominal atmospheres of 6. Okay. Let's take an angiogram for them and see what we've achieved with this cutting balloon. So I have to congratulate Dr. Nov because she's working in a different setup than what she's normally used to, but actually she's superb with that. Right? Here's an angiogram of what we've done. I think it sort of shows that it's yielded a little bit better at the inlet of the aneurysm. So I think I'm happy with the drug-eluting stent if the folks on the panel are in agreement.
Yeah, I think it should be all right. I think this question is of the size. We need to size it, the distal diameter, and then hope that the stent that we use can go up in the aneurysmal area as much as it can.
Yeah, so We're probably going to use Onyx over here for distally 4-5, which, as we said, can dilate. We can optimize it up to 5-5, which is what we got. And we're going to stop before the very ectatic mid-segment. So hopefully...
So Mirbad, maybe you guys bring the OCT again and we decide whether to go with a 20 or maybe a little bit long. I think if you go longer, you will be able to optimize with a larger balloon, probably.
I mean, data from Gary Mintz has shown that when you stent across these aneurysmal segments, they tend to thrombose off. So longer-term malapposition isn't such a concern. I, again, would probably not use a stent in this case. I would probably use a drug-coated balloon and be more aggressive with the cutting balloon. But I think what you suggest is, again, a very reasonable approach.
Okay, so what we're doing is we're setting up our OCT. Where? These are the noodle type, which make our life a little difficult. But I have where I'm good. Yeah. So here's the OCT coming through. What worked for us is actually to do shorter runs because really we want to assess the most disease segment. So I'm just going this far. Have we done
purge? No.
Okay. Do that. Are we ready for us to start this? I think they're ready. How much from here? Not yet? You going to restart? Okay. So we're going to do this run over. We actually didn't inject yet. So here you go. We've purged. Okay.
Good.
Let's go to the more proximal segment. We don't, I mean, the distal sense is fine. And I think the interest is here. Again, I think the panel can see these angiograms. You can see that we've, sorry, not the angiogram. Let's stick to the OCT. There you go. So you can see we've fairly cleared up the lumen in the more proximal segment. If we keep coming towards the aneurysm, please. So let's keep scrolling. Again, not a lot of calcium. We do see the diameter is reasonable here. So this is as we're coming to the tighter segment. Keep coming, please. Keep coming. That's the aneurysm. And then we're going just beyond the aneurysm. Keep going. So any thoughts from the panel? Do you think we should, I mean, I don't see any deterrent to stenting at this point in time because there isn't a whole lot of calcium and we did achieve lumen gain with simple, but I don't see the cutting balloon. I don't see where we actually did any cutting.
Yeah, we are observing that here, Mirbad, that there is no MASH modification at that minimum lumen area. So,
Yeah.
so maybe you click in there, there is no MASH gain lumen. So,
Yeah.
I think at this point, this is mostly fibrotic tissue. So,
Yeah.
if you have the cutting balloon there, I wonder if you go back with that cutting and create a little bit more of modification and go with a longer stent. Yeah, exactly, covering that distal segment. Again. So you're looking for a 33 stent or something like that, yeah.
I mean, I would probably go with a larger balloon, Mirvat, maybe a 3.5 that you were thinking about.
Yeah, so we have a 3.5. We have a 3.5 cutting that's open on table, guys. Here's that, please. because I do believe it was a bit undersized. Keep scrolling, please. Keep scrolling to the right. You. I want the inlet of the aneurysm where the tightest lesion was, where we presumably dilated with a cutting, but I'm seeing it's more fibrotic, as Natalia said. So there you go. So you see there, that is the tightest segment. You know, I don't know, went from 1.6 to 2.3, but still we don't see that, you know,
Yeah, we don't see
the
that
fissures
much
or fractures that you
modification.
want to see.
And in this case, it's important because you want to put the largest stent possible, right?
Got you. So these are unfortunately short balloons. So can we test please and make sure we're in the right place?
And maybe for the panel, based on the stent sizing, what size do you
So I'm
guys
going to start
feel
with the distal
they should
segment.
go
Let's
with?
just
Do you want to go distal?
yeah, let's test one more
Because
time.
the software is
No,
just
pull back a
detecting
little.
mostly lumen.
There you
It's
go.
not detecting EL. The lumen is kind of 4 ball, but we know we are going to be undersized. So what is the size? A Megatron 5 and maybe go.
Well, I think from what I saw on the OCT, the maximum was about 5.5, 5.6, and the distal looked close to 4. So maybe something, a stent which is 33 millimeter in length, which can start at 4 and then maybe in the middle part go up to 5.5 or 6. So I think the Nagomi or the Megatron both would fit that bill. I think both will go up to even 6.
more?
So
Okay.
I mean,
Okay.
before you stent, is it just worth doing a POBA, not even a drug-coated balloon, say with a 4 millimeter or 5 millimeter balloon, and just see what your result is? And if your result looks pretty good, then change to a DCB approach rather than jumping to a stent. Oh, sorry.
Okay, so we'll do one more run of OCT. We took a 3.5. We did the inlet and the outlet with the cutting. Let's see what we get here. And we actually went up beyond nominal of 6. We actually went up to 10. And we went up twice. Can you check if we have the Megatron?
So Miravat, how would your antithrombotic strategy change, or would it change in the presence of such an aneurysm?
Well, I don't know if you can see the monitor, the hemodynamics, but he does have paroxysmal atrial fibrillation. So he does have an indication for oral anticoagulation. So likely before discharge, he's going to need, so right now we're keeping him on triple therapy while in hospital.
Okay.
But then we're likely going to need to do, can I have some plastic? I have wire. Thank you. So then we're going to likely have him on single antiplatelet with an OAC.
Okay, great. And then after a year, are you going to continue just on NOAC, or are you going to add the antiplatelet?
Probably. I mean, he is low bleeding risk in all honesty. He's a very, you guys ready? I mean, I haven't really calculated his score, but, okay, so we're doing our second run of OCT. Ready?
many of these patients I've seen, at least in India, have a high HSCRP, apart from the lipid profile abnormalities that they have. And I generally, if they have that, apart from the use of, this patient needs anticoagulation anyway because he's on atrial fibrillation, possibly a low dose of colchicine may be a good idea of 500 milligram a day in the long run, because this is not simple atherosclerosis. There's some inflammatory disease going on around it.
So let's go back again. Yep.
Dr.
Let's
Mirawat?
go back a hair. Yes, ma'am.
Yeah, as we are short of time, can we call Kavita? We will swap to Kavita. Dr. Kavita, are you ready with your case?
So we're going to go ahead and send it. I think
Hello? We just continue with that, with the presentation from UK. Can we just continue with Saudi Arabia? Yeah.
So I don't know if we're still live, but the OCT, no, come back to the inlet of that, please. Yeah, you are around here. So we almost see some figures, but it's hard to see. There's one around, 12 o'clock, almost, 11, 12 o'clock, barely. We can probably take a high pressure and then stop. Yeah.
Well,
Yeah.
you're going from the small branch to the
Yeah.
next one.
I don't know if we're still live or not, but in any case, we are going to
Yep,
deploy the stent at this point.
yeah, we're watching you eagerly, Dr. Alasnag.
Okay, I wasn't sure if you had moved on. But in all cases, the OCT shows beginning of some fissuring, which I think we can probably do some more post-dilatation, high pressure NC balloons and stenting. We have chosen a Megatron, and we're taking a 32 because that's the length that's available in Megatrons, and then we'll go ahead with probably 5.0 or 5.5 NC balloons to post-dilate.
That's a great strategy.
Wire. Yeah. So can we go back to the Andrea Shabab? We don't really need to do the this again. Yeah. Ready? I think he's getting tired, so we need to work a bit faster. We have wire. We'll need a test soon, please.
You have the wire, huh?
Yeah.
Okay. Sit there. Hold it a little bit.
Virtual picture, right?
Yeah, that's good.
Ready?
Okay, working. Probably maybe 2 millimeters in.
Yeah. Let's test again. Okay, so the dot is actually before the stent. So we're just at the beginning. Maybe I can go in a millimeter.
There you go. Yeah.
That's okay.
That's good.
For that, please, Tahani, and for the yeah. So we're going to deploy.
Deploying of 14.
And that's for that again. Fluoro. Right, let's get our NC balloons, please. 5.0. Not the other one.
Dr. Mirawat, we will be back again live after you complete the case.
Sure.
Now we will swap
Thank
to...
you.
Yeah, thank you. We'll be back again and see the result.
Okay.
Madam Dr. Kavita. Yeah, you can...
What's yours? Where?
Angle.
No, we're okay.
Hmm.
Okay. So we stent.
I think you're good there, probably. But just in case.
So what are you post-dilating with there? What size balloon?
We're post-dilating with a 5.0. So this is. Okay, I think we're in the stent now. Yeah. Okay. I think we have a couple of. This is a 5.0 and balloon.
A bit in?
Yeah, I will go in one.
Just like 1 millimeter.
There you go.
Yeah. Oh, going up?
كيف حالك يا عم عثمان طيب؟
18.
That's the shoulder.
Yeah.
Can you store this one for me? Yeah. معلش يا والد سامحني خلاص قربنا نخلص يا بابا. الألم هذا مني. He's feeling a little bit of pain, but I think that's post-dilatation.
Virat, what we'll do now is, go to the lecture and come back to you once you finish, if you're okay with that, and an OCT.
Yeah, absolutely.
Yep. Thank you very much for a lovely case. So let's go to the next presentation.
Thank you very much for having us.
Yeah.
Thank you.
So let's go back to the bifurcation stand with the DK crush by Dr. Kavita Tyagi.
Very good afternoon. Next, please. So we had this patient, 72-year-old male, presented to us with non-ST elevation MI. He was diabetic, hypertensive with peripheral artery disease, hypothyroid, COPD, CKD stage 2 with EF of 50%. And angioplasty to circ had been done just 3 days back. Next, please. So this is the angiogram. We can see LED diagonal bifurcation disease, Medina 111. So we have taken up this case. Next, please, now from the video. No, but he has to run now the videos, actually. No, it is not the video. He has to run the video now. Hello everyone, I am Dr. Kavita Tyagi from Sir Gangaram Hospital, Delhi. Thank you so much, Vinkas team, for inviting me for this session. So today we are going to this live inbox case. So we have this patient who is a 72-year-old male, presented to us with non-ST elevation MI, and his angiography was done a few days back when circ angioplasty was done, and now we are having LED disease. So today we have taken up this patient for angioplasty of LED, and this is EBU 3.56 French catheter I have taken. I have taken through femoral route because patient's both radial arteries are not felt and patient is known case of PAD. So this is the LED and diagonal injection. So we can see it is Medina 111 bifurcation. And so now, because this is big diagonal and this is the only diagonal in the system, so I'll go for upfront bifurcation strategy. So we are starting this case. So this is cyan blue guide wire. And I have crossed diagonal with this. And another cyan blue guide wire. LED lesion has been crossed. Now, this is the 2.5 into 15 millimeter NC balloon, which I used for redilatation of LED. as well as diagonal. So both LAD and diagonals have been pre-dilated. And now I will do IVUS for both branches. So this is IVUS from diagonal branch. So this imaging is necessary to see whether we have to deal calcium. So we can see that there is no much calcium actually. And then this is the IVUS from LAD. So sizing, the distal sizing of the artery, and whether we have caused any dissection in the artery, and how much is the calcium burden, do we require some specific calcium handling devices. So for all those things, we did IVUS, and we were comfortable with our pre-dilatation. So now we are proceeding with angioplasty. So this is the stent I have taken for diagonal. So this diagonal stent is 2.5 into 18 millimeter onyx frontier, placed in diagonal. And before this, I have taken this balloon, non-compliant 3.5 into 12 millimeter in the mid-LAD. So this stent has been placed in diagonal. 3 to 4 millimeter stent has been kept in
Dr. Tyagi,
LED.
can we stop somewhere and discuss?
After placing this stent, I have removed the wire and balloon.
Can we
from
stop somewhere and
diagonal.
discuss?
And now I have taken this balloon up for crushing the stent of diagonal.
Pause it,
However,
pause it. Pause the video. Pause the video. No, it's very clear. No echo. Earlier it was. You need to do the second crush with the proper size.
Yeah. Yes, sir.
Yes, what's the main reason that you have chosen to do an upfront decay crush or two-stent strategy? It looks like a lesion to me with one bun, I agree. And I agree that there is a major side branch that we cannot afford to lose. But the lesion in the side branch is very short. And
But it is the
probably everybody, most of us, let's take a note. How much of you would go for an upfront bifurcation strategy? Can you raise your hands, please? How many of you do think of provisional in this bifurcation? That's okay. The second question is, you have thought of using two modalities, IVUS or OCT. Both are good, but the evidence is OCT has a trial, October trial, which has shown that it is beneficial in bifurcation with a statistically significant composite endpoint. Right? Now, if you are doing an IVUS, I would study the bifurcation of the IVUS before pre-dilatation, whether there is a chance of side branch closure or not, by looking at the bifurcation imaging modes. Whether the earlier speaker was saying, the eyebrow sign, the angle, the distance between the branch point and to the carina, these are things we see. So I would do, because I'm doing an IVUS, for this case, I would do an LAD IVUS first, followed by a side branch lesion, assess the size, assess the morphology of the lesion, how to prepare the lesion, then we follow up and do it. That's how I would do it. I'll ask Dr. Mamas his comments about it.
So basically it is big diagonal, only diagonal, and the patient had non-ST elevation MI stenting to LCX a few days back and CKD. So I planned upfront bifurcation strategy for this patient because it's a big diagonal and only diagonal at the side. And I planned for IVUS because patient is a little CKD, so I had not wanted to use OCT for that reason. And IVUS made my job very easy. In fact, there was no calcification. It was only fibroatheromatous plaque, which could be handled by non-compliant balloon.
Yeah, I think the LAD stenosis was very eccentric, right? So, but I couldn't appreciate by IVUS what was the plaque morphology at the carina, because probably I agree with some imaging features you could predict if that side branch is going to be affected. Other thing that you can do and I want to ask you, what are you doing here in India? How much are you using drug coating balloons at the side branches when there is just very focal disease instead of a stent? Like maybe just share what you guys are doing here.
Yes, we started doing it, and we are more comfortable in doing a DEB in that short lesions in the branches.
And one of the ideas of imaging is to get the vessel size right. So before implanting a stent in the side branch, because I have an IVUS catheter in hand, I would do an IVUS imaging of side branch to look at what's the best size. That's important. And the length and the size. And in my opinion, your stent so far is more into the LAD than intended, and still it looks a bit underexpanded at this point of time. Yes. Can you play it again, the video?
And this first crossing should be through the proximal diagonal stent strut. So I'm attempting towards that. And it won't go straight, so I took it down, and then finally I took it back, reverse looping, and I could cross it. Now I've taken the balloon, 2.5 into 12 millimeter in diagonal, and 3.5 into 12 millimeter in LAD. So I did sequential dilatation. First I dilated this balloon from LAD to diagonal. Then I took LAD balloon up, and then both. But again I would face the same thing. This LAD balloon will be not stable across along with other balloon. So, but after few attempts, we could.
Pause it, please. Pause.
So this is first kissing dilatation
Pause the video.
using AccuForce 3.5 into 12 in LED and
This phenomena will occur of slipping when you've not crushed the diagonal stent completely. So what happens here is that your diagonal stent is still not crushed completely with the LAD balloon. So the stent is a bit up in the LAD. So when you're deploying the next stent or the balloon, the whole thing will slip backwards. So it's very important when you're doing a DK crush, one, that you don't come too far into the LAD. Number two, you see to it that it's completely crushed with the LAD balloon so that you have absolutely the stent out of the way from the LAD before you do the next step. Because you saw in that picture twice the balloon slipping forward, which should not happen if the stent has been completely crushed.
So I did proximal side branch optimization before I moved the balloon. I took the balloon according to the distal size of the LED, but still it moved multiple times. In fact, I started from down because I had the lesion down. I had place for LED stand to go down, but then kept on milking, and once it came proximally, I could not deliver it again. So I had to take another NY balloon.
The current modification of the DK crush technique is, there are two crush initially. The first crush is with the balloon that is sized to the distal vessel. The second crush is the balloon sized to the proximal crush like you do a part. As Ajit was pointing out, if you were to do it, this wouldn't have happened. That's what he's saying. There is a second crush that is added to the original DK crush technique, doing a proximal crush with a balloon which is 1-to-1 sized to the proximal vessel size. Because you haven't done it, this is the problem we are facing. That's
This is a 3.5, while proximally it is 4 size. 5 NC 2.5 into 12 millimeter in diagonal at 10 to 12 atmosphere for 20 seconds. So since it took multiple attempts to stabilize the balloon, so after first kissing, we repeated.
To the chairpersons, we are running a little bit late. We have to go to live again to Saudi.
الكاميرا الثانية حتسويها يا
توقفي وين ما تبين، نفس مكانك القديم بس يمين شوي.
اي بس لا تجيب صورة الرجال يعني.
ايه
انت شايفها؟
ايه هنا
طيب.
كويس.
الحين تجي بس بس الرجال مو باين ها؟
لا مو باين
لأنه مكشوف. يلا دحين تجي.
At 11 atmosphere for 25 seconds. So this is LED stent dilatation, deployment. Then I dilated.
Can you move forward?
Yes, to restart the video. Proximal part of LED stent
Straight forward.
with NC travel 4 into 8 millimeter balloon. At 14, 16, 18 sequentially and 20 atmosphere pressures for 20 seconds.
The ostium looks underexpanded, the ostium of the diagonal in this picture. It'd be good to image.
So this is sequential pot of LED stent. Now this is second time I am crossing the wire to diagonal stent. Ideally this should be through distal stent strut, but I am not sure whether I crossed it actually through the distal. Now second kissing. So we have taken AccuForce 3.5 to 12 millimeter in LED and Sapphire NC 2.5 to 12 millimeter for diagonal at 10 to 12 atmosphere for 20 seconds.
Yeah, we are doing some comments here that when you have that trouble getting the balloon, sometimes it's helpful to get a short NC distal in the main vessel to anchor your balloon into the side branch. You managed to get it through, but that's something that is commonly done. Well, it looks like a very complex bifurcation. You guys were very invested doing it, so it looks the amount of time you spend on this. Yeah, I find DK crash such a complex technique of bifurcation with so many steps. I usually only do DK crash if it's heavily calcified or if the plaque morphology at the carina is very complex,
So
because
the
the many steps are quite complex for DK crash. I wonder if anyone else in the panel will have done any other technique. If you committed to 2 stents, I think we kind of agree that probably provisional, but will you have done any other technique?
And this is report.
And also in your IVUS, what was the main plaque morphology? Was fibrotic. I saw the IVUS very quick, but
balloon.
what was it? Fibrotic, yeah. I find we
40 to 20
feel
atmosphere.
fibrous tissue is very benign,
For
but I
20
don't think it
seconds.
is. It's actually as complex as this, right? The stents don't open well, and you have trouble
In LED?
optimizing. So I wonder if you would have used cutting balloons pre-stent, if it would have made this any easier. Probably. I don't know. What do you guys think about cutting?
Yes, let's see the last IVUS picture. IVUS from LED and IVUS from diagonal. Can you move it forward?
LED stent. So this is post diagonal stenting IVUS. We can see the struts well opposed. There is no end dissection as dissection. There is no hematoma. There is no Then again we took IVUS for LED. We have tried to minimize the use of contrast in between. We have taken only required minimal injections with the dye because patient has some kidney issues as well, and that is why we opted for IVUS and not for OCT. So this is LED. We can see well opposed stent slits. A good luminal area, no edge dissection. And we can see nicely opened up.
Did you have any feeling that the ostium of the diagonal was underexpanded when you did your IVUS?
Stent slits.
The diagonal was underexpanded at the ostium, or what was your feeling?
Diagonal ostium.
No.
This run is from LED or diagonal?
So this final IVUS run of LED.
Oh, LED.
What was the stent size in LED? 3.5?
So this is the last angiographic run.
So we could complete this case with good results. We confirmed the stator position and entire LED and diagonal through IVUS, and we had good angiographic results. And thank you so much for our team, Dr. Juhi, second year DNB resident, and our nursing staff, Ms. Anjali, and Mr. Sunil and Mr. Anil. Thank you so much.
Thank you, Dr. Kavita. It's a nice case, nice demonstration.
Switch back to the live case, please.
Yes.
Live case.
Thank you.
So Dr. Alice Nag, we're in anticipation, waiting to see what you guys
We're here. I don't know if you can see us. This is Nof and I are here.
Yes, Mirat, we can see you.
Okay, so Nof is going to give you an update of the case. Can we play the angiogram, please? Play the angiogram, after angiogram. Or the final image.
No, we cannot see the
angiogram. It's not playing, Mirvat.
I need you to just play the image. Just play the angiogram. The one on the screen right now, just play it.
لازم من هناك يا فندم.
لازم من هنا تعال. من هنا play it. All right, we should be playing now.
I need the OCT as well.
Yeah, we can see it.
So as you can see, we managed to deploy a 4.5 by 32 stent. It was post dilated with a 5 ONC balloon, and we managed to get a good result. If we can see the OCT images as well, please.
So put the OCT on the main screen, guys. The OCT on the main screen.
Yes.
Yeah?
Okay, so we're going here from proximal edge of the stent. As you can see, it's well expanded and well opposed. We're here going into the aneurysmal segment, and obviously we're happy with the results here. And this is the distal segment of the stent just beyond the aneurysm, and as you can see, it's well opposed, well expanded. We didn't see any dissection at the proximal edge of the stent, and we're heading now towards the distal end of the stent, and as well, we couldn't see any edge dissections there.
It's a great case. Congratulations.
I think the OCT was reassuring. No edge dissections proximally or distally. The only segments with malapposition, gross malapposition, is within the aneurysm. I don't know if it's my imagination, but even the angiogram starting to show the aneurysm looks smaller, but I don't really know. But in the other remaining segments, I think a Megatron stent post-dilated with a 5.0, I'm sorry, seemed to do it, and I'm pretty satisfied with the results.
Thank you for a lovely case. Can you tell us what is the dual antiplatelet regimen you're using with the anticoagulant?
Correct. So at this point, he's on aspirin and clopidogrel and apixaban in hospital. And then when he goes home, he'll be on clopidogrel and apixaban for a year. And then hopefully, and the reason it's a year is, it was an APS at the end of the day, and he is low bleeding risk otherwise, aside from his DOA.
Thank you. I think for the benefit of the audience, there's no data with apixaban or any NOAC with ticagrelol. So we need to be very careful when we combine antiplatelets with anticoagulants.
Absolutely, yes.
Thank you. So I think on behalf of all the chair and the panel, thank you very much for a lovely case. Yeah.
Thank you for having us.
Now we move on to the debate. For this session, I invite onto the dais the chairpersons for this session, Dr. A.C. Nagamani Madam and Dr. Ritu S. Valinchkar Madam. And the expert panel being Dr. Natalia Pinilia, Dr. Seiko Takahashi, and Dr. P.K. Saho, and Dr. Monica Bandari Madam. And as for this session, we are going to have a debate on imaging should be done for all PCI. For this, yes, it is mandatory, is being argued by Dr. Mamas, and no, only in select situation by Dr. K. Gopalakrishna sir. In this session, we'll have 12 minutes for the talk and 3 minutes for the rebuttal.
So where's the button? So how do we start this? Can we put the slides up, please? Can you put the slides up, please? Great. Well, I look forward to debating against my good friend in the audience. So over the next 10 to 12 minutes or so, my focus is going to be why I use intravascular imaging in every case. I've used intravascular imaging in 100% of my PCI over the last 4 or 5 years. I haven't done a PCI without imaging. So interventional cardiology is like driving a racing car. Given that we're in the Win Cars meeting, I've chosen a pink racing car. Teamwork, state-of-the-art machinery, delivering best evidence. But trying to do PCI without imaging is like trying to drive with a blindfold on. And it doesn't matter whether you're on a very straightforward road, like the Highway 10 in the Kingdom of Saudi Arabia, the world's longest straight road at 256 kilometers, or a very tortuous, complex road like the Circuit de Monaco in the streets of Monte Carlo. Wearing a blindfold is not a good idea. That's why you have to image in every case. And when people say that, oh, but I can see when I need to image on the angiogram, the most dangerous obstacles are not those that you can see. They're not the big rocks in the road that everyone can see. It's the smaller rocks that you can't see. So over the next 10 minutes or so, I'm going to address 5 points. First and foremost, I'm going to show that RCT data shows that even simple lesions benefit from imaging. Secondly, I'm going to show that imaging is cost effective. Thirdly, I'm going to show that even if you image in some cases, it doesn't give you superpowers. It doesn't give you IVUS eyes. You need to image in all cases. And I think finally, if we have time, I'm going to talk about when imaging helps you decide when not to stent as well. So when people say there's not enough data for this approach, they're wrong. This is a paper that we published recently in the BMJ showing that intravascular imaging is associated with an improvement in a number of different outcomes, both in terms of myocardial infarction, in terms of stent thrombosis, in terms of target vessel revascularization, and all-cause mortality. This is the important slide. What we looked here at was benefit of imaging in different complexity. And if you look at the red box at the top, that's in low syntax score patients. And you can see that in terms of absolute risk reduction, imaging still has a significant benefit in low syntax score patients. So you shouldn't reserve it just for complex cases, even simple cases benefit. Now, the ESC guidelines say there's less benefit in simpler lesions. That's wrong. This is data from the Ultimate trial, a landmark randomized control trial, showing benefit in terms of target vessel failure, TVR, and stent thrombosis. Again, look at this figure. The benefit is there irrespective of complexity of lesion. It's there in simple cases, it's there in complex cases. Now, my friend may say, oh, it costs too much to do imaging in every case. Again, that's wrong. This is data from Australia showing that intravascular imaging over the lifetime horizon meets the QALY criteria in terms of less than 25,000 per QALY. This is data from the United Kingdom published by my collaborators and myself. Again, showing that within 2 years, using intravascular imaging routinely for acute coronary syndrome is cost effective. Now, my collaborator may say, well, I have IVUS eyes. I'm magic. If I can tell by doing some imaging, my skills are better and I can get better outcomes even when I don't do imaging. That's a myth. That's wrong. This is data from the Renovate Complex PCI trial. And what they did here was look at outcomes during the trial just for angiography alone versus historical controls. And again, no difference. So doing imaging does not give you IVUS eyes. That's just completely wrong. They may say it takes too long. Again, that's a myth. In our analysis, it suggested that it perhaps may increase procedural time, but for each minute that you spend doing intravascular imaging, you prevent 1 cardiac death, 1 heart attack, 1 TVR, 1 target lesion revascularization per 1,000 patients. So it may take a bit longer, but for each minute, you may save 1 cardiac death. You may say, well, okay, I can tell on the angiogram when I need to use imaging. And again, that's not true. This is data from my good friend, Gary Mintz, from 30 years ago. And what that shows is that even in experienced eyes from the CRF, you really can't tell what's significant calcification just from the angiogram alone. Even in lesions where you have 180 to 270 and close to 360 degrees calcification, you cannot tell from angiography alone. And we've seen this data time and time again from Akiko Mehara and so forth. Imaging is also useful because it provides you insights whether you need to actually stent. This is data from Erosion 2. Erosion 2 looked at whether plaque ruptures or erosions can be left alone and medically managed if they have a good MLA. And what you can see here is certainly for erosions, you have good outcomes at 1 month by not stenting. And again, using this case, you can see that you may stent this without imaging, but you can see that it's a clear erosion with imaging, and so you leave it alone, and it's a month, you've saved this patient stenting. So again, doing intravascular imaging in every case helps. Finally, we know that imaging can help with defining what a high-risk phenotype is, dependent on the presence of thin cap fibroatheroma, MLA less than 4, and a plaque burden of 70%. If you have all of those three factors, you have an event rate of close to 20% at 3 years. We also know that thin cap fibroatheromas are associated with increased risk, increased event rates, both from the combined OCT-FFR trial and from this study as well. Why is it important? Well, it's important because it identifies patients at high risk of events, and therefore you can treat these patients and target these patients with optimal pharmacotherapy, and in this case, PCSK9 inhibitors. Both Huygens, as well as Yellow3 and Pacmanamide, have shown that intravascular imaging guided PCSK9 inhibition can deliver regression of plaque, increased stabilization of plaque, and therefore better outcomes. And certainly when doing these analyses, you're not going to be able to identify these high-risk plaque phenotypes that you can treat percutaneously, as in the PREVENT trial next month at the ACC. I think these final couple of cases show when it's useful. So this is a case of a patient with cancer that came in with ECG changes and an ACS. Many people would look at this and treat it. That would be wrong, because when you do the OCT, you can find this is a stable lesion. This lady had lung cancer and came in with a Takotsubo. She had an operation a few days after her presentation. Not doing imaging in this case, you would have stented, you would have delayed the operation. Again, a young Hep B patient presenting with anterior changes. A focal lesion, type A lesion. Why do you need imaging in this case? Well, the reason you need it is because it's not an ACS as we understand, but a SCAD. Again, if you don't do imaging in this case, you would have missed it. You would have given this patient an unrequired stent. So in conclusion, intracoronary imaging should be used for every case. Randomized trials show no difference in the benefit of imaging for simple versus complex cases. That's fact. Imaging is cost effective. We have data from 3 countries. That's fact. There's no such thing as IVUS. Finally, imaging can help you decide when not to stent, identifying high-risk patient phenotypes that can be actioned, in this case, giving PCSK9 inhibitors to stabilize the path. So my final takeaway message is, don't drive with a blindfold on, don't do PCI without imaging. Thank you.
Good afternoon, everyone. Thank you, Vinkars, for giving me this opportunity. And Sujata has put me a tight spot, debating with Dr. Mamas, a great academician, interventional cardiologist, and internationally renowned key opinion leader. So I wanted to approach Dr. Mamas' debate in 2 ways. There's only my strategy of winning the war. The first thing is to get your support. Next slide, please. Next. Okay. So, how many of you do imaging, as Dr. Mamas was telling you, in 100%? Except Dr. Mamas, nobody would. Natalie, do you imaging in 100%? 75. So, how many of you at least in 25% of the cases? Oh, that's good number. I like it. So, I have you on my side. The second thing is, I want to say, I disagree with Dr. Mamas. I have to say first, I agree with him. let's look, that's what Dr. Mamas was telling you, that it's not a good idea to ride the bicycle without lights in the night. So if you have a lights, you can, as Dr. Mamas was telling you, that you can have calcium nodules, the road, and you can get over them very well. But he has shown you that number of RCTs and registry data has shown improvement in the MACE, meta-analysis, death, all-cause death, cardiac mortality, stent thrombosis to the extent of 52%. But in your routine practice, you encounter a patient like this who has a limiting angina, not ACS, and this straightforward lesion. Do you think of doing imaging for this case? Each case is different. Similarly, I don't need lights to ride in the broad daylight. And even in UK, the legal requirement to use lights only between the night, not in the daytimes. So the potential indications or what we have in these trials is we have seen a mixed bag. But the patient comes to you at few of these indications, clinically at the CKD or ACS, anatomically there's various lesions where potential benefit with intracoronary imaging is there, a procedural with PCI with DCB. So you can use a different modality as an IVUS or OCT depending on the anatomical considerations and also the clinical consideration. You can use either of these modalities. One of the emerging modalities is the CT, where you can do a planning even before doing a PCI, doing the cath lab. So I will address this in the next 10 minutes. What is the evidence? What is the real world? What are the roadblocks and what are the guidelines? The evidence. The CTO, we have evidence. There is an RCT showing definitely IVUS-guided PCI decreases cardiac death as well as MACE. In left main disease, this is a meta-analysis of 18 trials which has shown a significant decrease in target lesion failure, all-cause death, cardiac death. And that's the optimal trial which was going on, which is presented specifically addressed to the LM disease. And in CKD, the CKD subset in the ultimate trial has shown significant benefit. The benefit in the CKD patients is much more than the patients without CKD. The same results have been reciprocated in the Renovate complex PCI trial. In the ACS also, you have a definite evidence that image-guided PCI decreases MACE, cardiovascular death, MI, and target visual lesion revascularization. In complex bifurcation, the October trial presented in the ESC 2023 has shown a composite endpoint benefit in complex bifurcation. Not all, complex only, not simple. The long lesions, this is the data from IVUS XPL and ultimate trial, and the lesion is more than 28 millimeters, definitely imaging is beneficial. That's using IVUS. Coming to the calcified lesions, we have seen the use of imaging in the calcified lesions. Every conference you go, you talk about calcified lesions. This is the EAPCA consensus document. It says, you look at it, it says, the best guided by intravascular imaging, only one sentence, that is in the left main disease only. In fact, this consensus document contains a recommendation, an algorithm for doing a PCI in calcified lesions using CT and angiogram, not with imaging. That's the algorithm. And the pre-procedural CCTA, the current CT angiography, the calcium score is more than 453 or the ARC is more than 220, they recommend using a tool. That is pre-procedural planning using a CT. And coming to the stent failure, you have seen in the morning a live case where imaging is strongly recommended, and this same EAPCA document says, consensus document says that evidence is lacking. There is no evidence in stent failure that doing imaging gives you better results compared to doing not imaging in treating these either stent thrombosis or ISR. In PCI DCB, you look at the endpoints, or starting points, beginning points, or either angiographic, severe stenosis that's relieved, less than 30%, or a good flow, both less than type 2 dissection, or a physiological endpoint, but there is no imaging endpoint. So now, coming back to our indication, we have evidence in CKD, we have evidence in ACS, we have evidence in CTO, we have evidence in unprotected left main, bifurcations, that too complex, long lesions, but the evidence is still to emerge in calcified lesions, stent failure, graft disease, Minoka, and in PCI with DCB. What is the real world? This is the use in EK. This is from the London registry, which was done long back, and the use is pretty low. But low rates of usage in that, presently it is all over the UK, it is around 25%. Probably Dr. Mama's center, Dr. Mama's may use 100%. How about his other colleagues? Probably it will come to less than that. Even in the USA, this is the Medicare data shows very low usage of imaging. The OCT or IVUS, even though the results are better with IVUS and OCT compared to angiographic guidance. Now, this is the recent data where the imaging use has increased in USA, now coming to 15.4%. And in my center, we use, slowly after the COVID, we started using imaging. This last year, our whole group has used 35%. I use around 72%. And the OCT use is more than the IVUS use. IVUS use has been catching up. This is in my center experience. And coming to this point, is the image-guided PCI okay? No. Just using imaging is not the point. So you look at these trials, and this is the randomized control trials done by experts. The achieved endpoints are only in about 50 to 60% of the patient. They have achieved predefined endpoint in just less than 2/3 of the patients. Imaging per se doesn't improve outcomes, but achieving optimal results definitely pays off in showing, compared to the optimal result to suboptimal results, either in the ultimate trial or IVUS XPL trial or Innovate Complex PCI trial. What are the roadblocks? High cost, longer duration, reimbursement issues, lack of training, and fear of risk of complications. The guidelines are also very not in favor of that. Either the 2018 ESC guidelines or 2021 guidelines to show that they are a reasonable alternative. They give a 2-year recommendation only, not class 1. There is a big push to give the class 1 recommendation of imaging in routine PCI. My take is the coming guidelines are likely to recommend class 1A, only not all patients, only a select group of population like CKD, CTO, left main disease, or acute coronary syndromes. In conclusion, definitely it's beneficial, which has been shown in the meta-analysis presented by Dr. Stone, and it's durable but lacks momentum. RCT evidence is yet to emerge in all the cases. The penetration of ICI in routine clinical practice is low. More training in use and interpretation is the need of the hour, and its use limit the usage of ICI to indication with established evidence. The ongoing trials are optimal in LM disease, in ACS, IVS SHIP in complex lesions, ISTEMI in ACS, that's the improved trial, and the prevent trial that is mentioned by Dr. Mamas. I don't need lights all the time. Thank you for your attention.
So I'd I'd like to congratulate my colleague for a very elegant presentation. I agree with quite a bit of what he said. I think in particular, intravascular imaging is not a magic wand, it's not a magic stick. Just putting the probe down does not give you better outcomes, it's actioning the results. And I think that's one of the areas that I think much of training has to focus on making people understand what are the intravascular imaging parameters that we're aiming for. The second point that I think is important to highlight is that absence of evidence does not equate to absence of benefit. So when you say that we don't have data for stent failure, that's not entirely true. We published the UK analysis in Eurointervention last year for stent thrombosis, and there definitely is a mortality benefit in PCI for stent thrombosis associated with the use of intravascular imaging. I think, like you've said, many of us in this room use it a lot. I think as cost comes down, as reimbursement changes, I think we're likely to use it more and more, and I think it's going to be much more widespread. I think most people will recognise there is a benefit. I think the main things, that, like you have said, is that it's cost, training, reimbursement, and maybe time. Those are the three factors. But if we have this debate in 10 years' time, I suspect that you'll probably be the same page as I am and using it in 100% of your cases.
I think in the end, Dr. Mamas has agreed with me, and we have to live in the world, the real world. And as we have seen, Dr. Mamas is an exception, doing in 100% of the cases, but we are the real world. He's not the real world. That's what I want to say. Any comments from the...
Yeah, beautiful talks both. you can, I think overall we could support both, because I think in real practice there are people, countries, healthcare systems that allow to use 100% imaging. I think Saiko can speak of in Japan, like they use 100% imaging. But I think the reality in most countries is that not 100% can be used, and I think the practice varies between even your own colleagues in the same cath lab. So I work with 10 people, some of us use it in 90%, some of the others use it in 10, 20%. So we balance overall, and most of the cath labs, if they like imaging, they do 40, 50%. But yeah, I think 100% is a lot. My worry is when we say, oh no, let's keep imaging for just left main, CTO, and bifurcations, is that if you don't do imaging in all cases, you don't have the knowledge to do a left main PCI with imaging. So we all have done CTOs with IVUS, and doing a CTO with IVUS is very challenging. Or false lumen, true lumen, dissection, re-entry. That's not easy. So you use IVUS just for those cases. I think the training curve is very challenging. So if one day you want to use OCT for a left main bifurcation calcification, if you don't do it in regular cases, you're not fast enough, you're not confident enough in the imaging analysis. So instead of the imaging making you like your case easier, it makes it harder. So then people don't like imaging. So I think that's what's important to use it in all cases if you could. Another learning point is that when you use it in a lot of cases, you learn from every case. And you think that something that is easy is not as easy. Something that you think is focal and not problematic could become problematic. So there is a lot of learning when you use imaging in a lot of cases. You know, if anyone, I think Hasaiko, you had to comment about Japan.
Because in Japan, one imaging device is always covered by insurance for all the cases. So we don't have a reason we don't use the imaging. So once you get used to imaging guided PCI, you feel sorry if you don't perform imaging guided PCI for the patient. So we don't have debate for this in Japan. So we need light all the time. How about India?
I think everybody likes lights and everybody would like to have lights. But in a resource-driven country, I think we'll have to go with Sir, that we will select our cases and will continue to maybe have better knowledge in patients where we need to really use them. Because for years we have done angioplasty without imaging, but I think we could be wiser using them in selected cases. So in a resource-driven country, I would go with Sir. Thank you.
Thank you all. We will move on to our next session. This is about imaging and physiology. I request onto the stage Dr. V. Sujata, Dr. Sarita Rao to chair the session. Our experts will be Dr. Natalia, Dr. P.N.S. Harita, Dr. Priya Palimkar, Dr. Rajni Sharma and Dr. Hetan Shah. Dr. Rupali Khanna will be our moderator. So the first speaker will be Dr. P.L.N. Kapardi. He'll be talking about deciphering the role of stent design and polymer for long-term outcomes. All the chairpersons, experts, moderator, and the speaker onto the stage, please.
So this session we can start with first talk, and it's basically deciphering the role of stent design and polymer for long-term outcomes. And I think we had a morning session also in the live case that which stent to use and where to use. And Dr. P.L. Kapardi sir will, I think, give insights into the very pertinent topic in which we have the first generation, second generation, now the third generation stents. Thank you.
Technical team, can we have the slides, please?
Good afternoon. Good afternoon. Good afternoon, everybody. And my sincere, at the outset, I am thankful to Wincars and Dr. Sujata Madam and Josna Madam for giving this opportunity. And as we know, the Jain's stent is long-lasting, and in majority of the nowadays majority of trials, every stent is tested with the Jain's. So today I want to discuss regarding the decoding the role of stent design and polymer for long-term outcomes, especially durable polymer. If you see the natural history of the stents in 2000 Cypher stent, the stent thrombosis and long-term or late instant thrombosis, all these are attributed to the polymer. So there are trifurcation of these stent designs came. The first is the durable polymer, the second one is biodegradable polymer, and third one is a bare metal stent with a drug coating. So next slide. Next slide. No, sorry. So these are the fundamental questions. Are polymers the cause of poor DES outcomes? Are all the vascular responses to all polymers the same? Could some polymers be beneficial? Returning the DES to a BMS-like state lead to better outcomes? Let's discuss the scientific evidence. So once the material will be introduced in the blood, within 1 second, it will be coated with adsorbed proteins. So that is with a single layer. And this is the hypothesis in 1974. The higher albumin to fibrinogen ratio on the surface are desirable. So ability of the albumin not to be displaced by undesirable proteins is good. And once they become protein adsorbed on the surface, again it become eluted. So how tightly is the protein stuck to the surface is more important than the ratio between adsorbed and retained after elution. So this is the ratio 2 hours albumin absorption from pure albumin solution. If you see, once this that PBDF HFP polymer is associated with the optimal ratio where the albumin absorption as well elution will be optimal, so that it will be compatible with the blood and which will reduce the platelet adhesion as well as the aggregation. So this is the concept of fluorinated copolymer, which is a ultra pure copolymer composed of polyvinylidene fluoride and cohexafluoropropylene, that is VDF HFP copolymer. And this ratio, especially this material used in cardiovascular, neurological and ophthalmic sutures for biocompatibility. And this ratio and thermomechanical properties allow the optimal coating toughness and cohesive adhesive properties. So strong covalent CC and CF bonds provide chemical stability and which produce excellent blood compatibility. And this is the fluoropassivation concept, where the observed blood contact phenomena of fluorinated surfaces eliciting decreased local thrombotic response and faster rate of endothelialization. And this will promote or will minimize the platelet adhesion and activation as well as leukocyte recruitment. So this will modulation the host material interface by this fluorinated surface combined with chemical stability. Ultimately it will use cellular response to be conductive for the healing as well as minimal chronic inflammation which was attributed to the polymer. And these are the contemporary DES platform, the stud and coating thickness. If you take the stud thickness around 79 to 81 is optimal for maintaining the radial strength, very important. And along with the polymers in different stents, if you take Zynes, Resolute, Biomatrix, Synergy, Biomime, Ultimash and R0, the polymer that is a fluorocopolymer for the Zynes compared to the other polymers like PLA and Symbiosis, PLGA polymer as well as PLLA, PLGA polymers. If you take all these, this is the one which in vitro studies it was shown that Zynes consistently show the reduced platelet aggregation as well as activation, the thrombosis and inflammation as compared to the biodegradable polymer DES. If you see this photo micrographic images, if you can see, the Zynes is associated with a less platelet adhesion as well as aggregation compared to the other stents like Synergy, R0 and Nobori and Biomatrix and Ultimaster. And this is a confocal microscopy of the stent models if you compare the Zynes and BioFreedom and BMS Vision. So the positive staining area indicates the platelet adhesion and aggregation which is least with the Zynes stent. And not only that passivation of the platelets aggregation, adhesion and aggregation, but also if you say the intimal healing, if you neo-intimal healing, these Zynes, if you see the fluoropolymer, it demonstrated sustained safety as well as stability. At 48 months, this fluoropolymer is intact, offering long-term protection without inflammation. There is a healthy neointima developed at the end of the 48 months. So, not only this in vitro studies, but also it was a simulated COVID-19 cytokine storm, which is the mainly thrombogenic state. First ever preclinical study to demonstrate the safety of the fluorocopolymers in COVID-19 cytokine stimulation, and the stent thrombogenicity were as accessed in the state of hypercoagulable in the presence of cytokine storm. And these are different stents which are compared: Onyx, Synergy, Cobra stent, and they are coated with the fluoropolymers subjected to IL-6 as well as the TNF-alpha interleukins, and platelet adhesion and neutrophil activation were accessed by means of immunofluorescence. And so this is the, which was shown that almost the Synergy shows highest thrombogenicity in simulated cytokine storm, where the platelet adhesion values were significantly lower in coated Cobra stent and uncoated Cobra stent. So, indicating the difference of the fluorocopolymers in passivating the platelets adhesion as well as aggregation, which is a highly thrombogenic, that simulated that cytokine storm. And not only in the real world also, as we see nowadays, the short depth therapies, leader free as well as Onyx one, as well as the Twilight Synergy and ultra short depth one with a different stent platforms. Ultra short depth one where the Jains is also with a 28 days and 90 days, the short depth followed by single antiplatelet like ticagrelor, showing the high patency rates with low thrombogenic states. And not only this one, nowadays the new baby, that is a Jane Sierra, with a design changes, especially the connector has a little bit changed. The smoother flex link for the connector, which showed the easy crossing deliverability as well as the trackability, and narrower crest of the and tighter nesting of this connector accomplished the lower crimp profile, as well as these connector showing elongated bar arms for greater post dilatation, that is expandable properties was increased almost to the 5.5 millimeters for the Jane Sierra. And the two-layered the balloon, alpine balloon, was reduced to single layer, supporting better crossing and flexibility in challenging anatomies. That is, the bulkier balloon becomes less bulkier. And then the expansion rate also increased because of the flexibility of the connectors, that is 2 to 3.25 millimeters to 3.75 and 3.54 to 5.5 millimeters. That is a higher expansion rates for the Jane Sierra happened. And with this background, just one simple case I want to present. This patient presented with inferior wall MI, and after RCA stenting, non-culprit vessel, that is a diagonal which is angulation with a jutter from LAD, both from LAD to diagonal, and diagonal proximal segment has the bends, and this was pre-dilated with a 2 into 10 millimeter balloon, and then it treated with a 2.5 to 15 millimeter Jane Sierra, which a good trackability, and with the bend it has a good conformability also, and then subsequently dilated with the 2.5 10 to almost 20-22 atmospheres with a good final result. So this fluoropassivation durable polymer concept is more important, making the Janes unique in low thrombogenic as well as long-term patency rates, so that the adhesion aggregation in the acute phase will be minimal, and long-term and endothelialization, rate of endothelialization is more, along with the low-grade inflammation, preventing the late instant thrombosis and high patency rates. And with a new generation, the Janes Sierra, having a little bit modulation of the connectors, it has a property of the trackability as well as the deliverability, and with high expansion rates, almost to 1.5 to almost to 2 millimeters expansion rates from the previous generations. Thank you.
Great talk, sir. So along with the polymer biodegradable and polymer stents, what's your opinion on the stents design? So open cell and closed cells design, what do you think that is the future now?
No, the design is stud thickness plays a significant role in long-term patency rates, especially the restenosis rates, neointimal hyperplasia. The stud thickness is less, definitely the neointimal hyperplasia is less. As the stud thickness is more and more, the neointimal thick pathological neointimal fibrous tissue will develop. That is one of the contributing factor, along with the stent thrombogenicity. And of course, stent design mainly open or closed cell design, mainly the radial strength and trackability. And every stent industry, they will come with a different properties. Nowadays, everybody is concentrating on the expansible properties, concentrating on the left mains. So the Giants coming with the Giants Sierra, whereas this synergy coming with the Megatron synergy. And Nobori, Ultimaster now, the next generation, that Nobori, all of them, they want a high expansion property so that if there is a disparity between the proximal and distal vessel, these stents are very, very useful, not only for left main, but disparity of the non-left main vessels.
So any comments from the panelists? So in your practice, Dr. Siko, any comments?
I just wanted to ask you, that, what do you think that, so whenever we say, you said that thinner the struts, less will be the neointimal hyperplasia. But thinner the struts means also less loss of radial strength. Second is, more we expand the stent. Nagomi, Megatron, and now Sierra, all are hyper-expansive stents. But the moment we go into hyper-expansive, if you see the product monograph, actually there is a dotted line, which means that we don't have full data on the dotted line portion. Also, I feel that the more we expand the stent, do you think there'll be loss of radial strength? 3.5 going to a 5.5, a 2.25 going to a 3.5, a 4.0 stent going to a 6.5. Do you think we are going to alter the geometry?
No, actually they brought that little bit design. Once you become hyper-expandable, where the connectors are 2 compared to the 3 connectors in the distal segment, so that it won't lose its radial strength. Actually, they designed like that. But stud thickness definitely plays a significant role in radial strength. So ultra short thin stents, actually, we should not put in for the left main where the radial strength is mandated.
I agree. I think there was a benchmark testing also. When it was overexpansion, the polymer degradation was an issue which was expected that it might hamper. But it never, clinical results never showed that way. So we can, if they give the expansion limit, that it is going to expand that way.
That's why actually the lesion preparation is mandated before stitching the stent.
Thank you, sir, for a very enlightening talk. So we can go to the next lecture by Dr. Ajit Mulashri, sir. It's a 4P OCT image acquisition, capture the perfect. Said Dr. Netley also said you should have a good image for interpretation. So just doing imaging will not help, and I think Ajit sir will give us, enlighten us with how to do the imaging.
Thank you, Rupali, and thank you very much, WinCars, for calling me once again for this meeting. And I think me and Mamas have been here for every meeting of WinCars in the last few months. So let me just go to a simple talk on what are the simple P's that you need for a good picture. If you don't get a good picture, you can't read the picture. So the first P is to purge your catheter. Now, if you look at this whole thing, you can see that the catheter has to be dipped. You have to have a good 3 drips in the catheter so that the catheter is clean. If you have any air or dye inside that, you are not going to get a good picture. So purge the catheter with a media, flush media, 3 drips. Connect the catheter to the dock. And remember that you can inject dye either through an injector or manually. I prefer an injector because it's continuous, the flow. And the left coronary can take 4 cc's per second with a total of 14 cc. The right can take 3 cc's per second to a total of 12. Large vessels like grafts can take up to 20, again 4 cc's, and a manual injection, the maximum is 16 cc's in a 20 cc syringe. The key is adequate clearance time and not volume on automatic pullback. And that's very, very important when you take a good picture. The next thing, when I'll show you the picture next, select the pullback length and acquisition mode. And this is very important before you start taking the picture. I like manual pullback in certain scenarios when it's small vessels, very tight stenosis, where sometimes the catheter won't move back on automatic pullback, or extremely large vessels when I need to have, and when you're dealing with sometimes in the ostium. So these are the areas where you should use a manual pullback. The catheter has an imaging core inside, there's a lens here, there's an imaging sheath, and there is a side port where the drip happens. Now, when you take a pullback length, you need to know, what are you looking for? Do you want high resolution or do you want length? And this determines whether you take a 54 millimeter or a 75 millimeter, and you have to adjust your frames per second accordingly. For example, if you want a high resolution image, we would use a 54 millimeter 10 frames per millimeter at 3 seconds. While if you have a long acquisition, when you want a bigger length to balloon, you will take a 75 millimeters, 5 frames per millimeter with a 2.1 second pullback. So this is important before you decide what you want to do. Now, the first part is outside. Once you've checked that the catheter is working, you have to then decide inside the body to find the region of interest. So after you calibrate the catheter outside, you got the eye on the catheter, you monorail the catheter quietly, and then to the region of interest is what you have to do. Now, if you look at this, there's a distal marker on the OCT catheter, there's a proximal catheter marker, and there's a lens marker. And this is very important for you to do. The lens starts away from the distal marker, so please keep the lens marker at least a few millimeters, 5 millimeters at least beyond the lesion. Otherwise, you'll miss the lesion when you're trying to pull the OCT back. Number 2, engage the guide catheter, and you should not have side holes. And that's very important, especially when you're doing an OCT. Remember, the arteries are always responsive to nitroglycerin, and make it a habit, whether you're doing OCT or IVUS, that you use liberal nitroglycerin so that you get the right sizing. Now, the enable live image and inject flush media to deliver nitroglycerin ensure an adequate. So there is a live image. I'll show you the picture in the next. That should be done to deliver nitroglycerin and ensure adequate blood. Do not waste contrast, because we want less contrast to be used. As such, we are using contrast for OCT. We can use saline in some patients, but please try to less use contrast for the dye issues. And purge the catheter nicely. This minimizes signal damping. So let's look at, here's a lesion, and we have a catheter here. So, you know, your lens is here. Your markers are about 20. You can see one marker here, you can see one marker there, and you can see the other marker here. So this is where the lens is just proximal to the second marker. So there is 2 markers with 20 millimeters, and the lens is before that. And that's very important for us to understand. So proximal marker, lens marker, and a distal marker. That's what you need to do. And your region of interest has to be in between the lens marker and the proximal marker. That's what you need to look at. So if somebody can help me to just click on that video, because I can't do that from here. Can you click on that video? Okay, so this is how the OCT guide is. So the nurse is helping us to flush the catheter. Once the catheter is fully flushed out and clear, she opens the cover, and it has to be done in an aseptic way so that you don't get into trouble with infective issues. So you hand it over to your tech or a physician assistant who's helping you, and he pulls back the catheter into the plastic module. As you can see, it's very important that you put the male and the female dock in the correct way so that it doesn't get broken. And you wipe your catheter next to activate the hydrophilic coating. It's very important you wipe it so that it's very important to do that. Connect your syringe filled with 100 cc contrast in your injector. Purge your catheter, as I said, drape the dock using a septic technique and connect the catheter. The sterile operator is to secure the dock sleeve septically. Ensure that the dust cover on the dock is opened and secure. Instruct the sterile operator to place their hands in the inner fold of the cover. And that's the common mistake. When you're docking the catheter, you become unsterile. It's very important that you know how to do it. And I would suggest that all nurses are trained outside the lab to do this. Clamp as necessary to maintain the sterility. Now this is the manual contrast. You should have at least 20 ml syringes. You don't need to do it hard. You need to have a continuous injection. It should be 14 ml and 100% clean contrast. You should not mix it. These are the injectors. You have various types of injectors. I use my normal injector, which I use for my cath lab work. So this is the dock, and you can see the green connector, and that has to be docked correctly. Do not touch the inner fiber topics when you do that. And that's very important. Can you play the video, please, once more? So this is how the nurse would help you. Just put it out. These are very simple steps, and most of the problem starts if you don't do these technical and then you get a fault. You've injected 20 cc dye and then you don't get a picture. Next, please. And then you position your catheter lens distal to the lesion. Purge the catheter lumen via the side port. There's a side port on the catheter. We use 3 cc syringe. And be very clear that the dye is clearing through in the whole thing. Puff the manifold to verify the catheter injection and blood clearing, and then pull back the image. So in this process, once the catheter is placed correctly, there are 3 things that you need to do. Either you control the dock or your technician controls the dock, and you need to do a few things. You start your cine, you start injecting your contrast, and then enable the catheter. So otherwise, what will happen is you will not get the full picture when you're doing. So it's important to position, that's the first P, purge the catheter, puff the manifold, and then do the pullback. These are the 4 Ps that we need to know in the whole catheter. And these are the Dragonfly Optis catheter. I think most of us are used to it, so I'm not going to go into it. I think everybody should know the screens. They should know there are 3 things: pullback types, trigger, and acquired angio. And you need to know that. And these are all can be pulled down on the screen and used for what you want to do. So if you get a picture like this, it's not a good picture. There's blood swelling there. On the left side, you can see that. Clearly there's blood there. And you need to have a clean picture which is purged here to get a nice picture. In a live view, I always use a puff of contrast to evaluate the clarity and the guide catheter. If your guide catheter is out, you will not get a good picture. So be clear that you get an optimal clearance. And these are the auto-enable of the dock system or the auto-calibrate on the console if your technician is doing it. When the trigger is set to manual, I think press live view for the dock or the sterile, or live, and step off the cine pedal, view on the console, and auto-calibrate. So I think these are the steps that you need to do for the manual. And in the interest of time, I'll just show you quickly what it does. This is how you purge it. Then you press after you press your enable, you press it again, and then you start your pullback, and by the time you're already on cine and your dye injects. Automatic is important when most of the cases, I'm not going to go through it. Again, the similar thing, you go to live view, purge, enable auto calibrate, and then enable the auto pullback. When you remove the catheter, it's also important you don't damage it. So it's important to press the disconnect system and then disconnect the catheter in a counterclockwise loop. There's an unload button on the top, as you can see there. So sometimes, why do we press live view after we have advanced? Because the catheter is spinning at 20 frames and we don't want to damage the catheter when it's moving. So press the live view only after the catheter has passed the lesions, otherwise you'll damage the catheter. What's the main reason for injecting a puff of contrast in live view? To visualize the lumen clears the blood and the guide catheter is engaged. If the catheter doesn't pull back, what is the common issue? You set it on manual and you want it in automatic. Change your screen from manual to automatic. What are the guiding catheters? 6 French, no side holes, correct curve to engage the vessel properly, and you can use whatever you want, automatic or manual, according to the lesion. So, ladies and gentlemen, these are the simple 4 Ps. So, position your catheter, purge the machine, prepare the whole system, and then do the pullback. Otherwise, you'll get a bad picture, and that will help you not to do anything but repeat the procedure again.
Thank you, sir, for such a detailed discussion. I now call upon Dr. Lippy Uppal for her talk on application of
I think there's nothing that you can learn on a slide display unless you play with the machine.
Yes.
You have to play with the machine, and don't let your technician do it, you do it.
You do it.
Otherwise, you won't learn how to do this.
And initial runs, you might not get good, but try to have a good run and repeatedly. That will increase your play. Like you have to use it again and again to get a good views for that. Thank you. Thanks a lot, sir, for it.
I now call upon Dr. Lippy Uppal for her talk on application of FFR in a real-world scenario.
Hello. Good afternoon, everybody. First of all, I'd like to thank Winkar and BAM especially for inviting me on this esteemed podium. So, my topic is, I am Dr. Lippy, I am from Chandigarh. Okay. I am Dr. Lippy, I am from Chandigarh. So my topic of presentation is fractional flow reserve, clinical evidence and role in real-world scenarios. Next slide. You can change it from lecture. Yeah, the playback. So most of times, while intervening in chronic stable angina, we rely on coronary angiography. How we all know that coronary angiography is a 2D modality. And the major drawback of a 2D coronary angiogram is its inability to accurately assess intermediate coronary artery lesions. Especially we rely on our oculostenotic reflex where we see the lesion severity. However, other factors which affect the functional significance of the lesion like viability, the area of myocardium that is jeopardized, or the presence or absence of collaterals is often not noted. So this was the FAME trial, where we saw around 1,000 patients who were enrolled with intermediate coronary artery disease and multivessel disease. And there it was found out that among patients who were coronary angiographically assessed to have 50 to 70% of the stenosis, more than 2/3 of them had functionally non-significant disease. Another meta-analysis which showed that effect of FFR is the absolute effect of benefit of PCI is directly correlated with the FFR values. In fact, the maximum absolute benefit of revascularization is achieved at the lowermost FFR values. And as we move towards the normalization of FFR, the benefit decreases. In fact, above the normal range, the benefit of the FFR might not exceed the risks associated with the revascularizations. So these were the 3 trials, the DEFA trial, the FAME trial, and the FAME2 trial, who have led the basis of use of FFR in today's world and today's lesion specificity. So when is FFR used? Is invasive physiology study now only to be used for simple lesions as well as intermediate lesions? No, the answer is not true. In fact, it plays a major role now in multivessel disease, complex diseases like left main bifurcations,
long lesions, diffuse disease, calcifications, as well as anomalous lesions. When we reclassify patients based on functional syntax code, which, with the use of FFR, more patients can be managed medically, and FFR is supposed to accurately assess the long-term outcomes. In famous NSTEMI randomized trial, where 350 patients were randomized to either received FFR-guided therapy or non-FFR-guided therapy, FFR could reclassify the decision-making process in around 20% of the patient. Also, FFR-guided therapy was seen to be non-inferior to angiographic-treated therapy. So now we go ahead with some case examples. So she was 76 years old female. She came to us with angina of 2 months duration. She had normal LV function. This was the angiogram. So she had intermediate lesion in both RCA and LAD. We went ahead with IFR of both the lesions. There was no significant step up which was seen in the LAD lesion. The IFR values was well above the normal range, and hence she was continued on the medical management. Another subset for managing such patients with diffuse coronary artery disease. Now, assessment of functional pattern of coronary artery disease is very important, and serial lesions sometimes which are seen in such patients, they can have crosstalk amongst each other, and they can affect the functional significance of other lesions. In such cases, it is recommended that you relieve the more significant stenosis prior to assess the second stenosis. So this is how crosstalk between serial lesions occur. So if you have like a proximal stenosis, which is more functionally significant, it may overestimate the significance of the distal lesion. However, if the distal lesion is tight, it may underestimate the FFR value of the proximal lesion. Hence, it is advised to treat the tightest lesion first, or the lesion where you see the most step up. So in this case, we had a 48-year-old male. He was diabetic, he was hypertensive. He came to us with exertional dyspnea for past 1 year. The angiography was suggestive of 2 tandem lesions in LAD. In fact, it was a diffuse disease, but 2 lesions were significant, angiographically seeming to be significant. So what was the functional significance of these 2 lesions? We went ahead, we did an FFR. FFR was 0.75. A significant step up was noted in the mid to distal LAD. We went ahead, treated with PCI was done, and repeat FFR was taken, IFR was taken, which was 0.95. Hence, the patient was continued on medical management for the proximal lesion. Videos. Previous slide, please. She was a 67-year-old female. She came to us with angina and exertion, class 3. She had anomalous coronary vessel, such that all 3 coronaries were arising from the right coronary artery. In some scenario, we were unable to actually assess the LAD ostium because it was hidden behind. In multiple views, we could not make out. There was another lesion in mid-RCA, there was another lesion in distal RCA, mid-LAD, and L6 was diffusely diseased, all 3 arising from right coronary arteries. So we stented the RCA distal lesion. We stented the mid-LAD. The videos. Previous ones. Yeah. Previous one. Yes. Next. Next. So we stented basically the distal RCA as well as LAD, and then to assess for the ostium of LAD, we did an FFR. FFR was 0.84, and hence she was continued on medical management. It has been 1 year and she is doing well. Another challenging subset of the patients where we can use FFR is jailed side branch lesions. Coronary angiography, as we all know, generally overestimates the functional significance of jailed side branch lesions after provisional stenting. And FFR-guided side branch is a feasible strategy. Functional severity of the jailed side branch do not change, which has been shown significantly over 12 months. So this was a case. We had done LAD, and a diagonal was showing diffuse disease, stenosis up to 80%, supplying to large myocardium. We went ahead and did an FFR of the diagonal. This was the diagonal. These were the tracings, and IFR was 0.9. The patient was continued on medical management. So FFR-guided strategy is feasible for provisional side branch intervention, especially in patients who have bifurcation disease. If we plan to go ahead with provisional stenting, FFR is the modality of choice to look for side branch lesions where coronary angiography can overestimate the disease. If the FFR is normal, we can leave it on medical management. If the FFR is low, less than at least 0.8, then we can either go ahead with kissing balloon or stenting as required. Another scenario is low fractional flow reserve after PCI. Does it matter and is it common? Yes, it is common. And does it matter? Yes, it matters. Because studies have shown that over 2 years, the target vessel failure is increased in patients who have low post-PCI FFR. The strategy to assess is that if you find low FFR in post-PCI patients, it is best to assess on table whether that is in stent step-up or out of the stent step-up. If out of the stent, then it is better to treat the residual lesions, and if in step-up, then probably treat the in-step lesions, in-stent lesions, either better assessment with imaging, and then treat the further residual disease. But FFR is not without its pitfalls. It is a mechanical hyperemic index which is invasive in nature. The mechanical issues related to transducer, zeros, connections should be taken care of. There is always some beat-to-beat variations in measurement. It is better to take an average value. Damping by PA by guiding catheter should be taken care of. And then issues with catheter and side holes should always be noted, and these things should always be taken care of. Then there can be a gradual change in FFR values because of wire signal shift and drift, and continuous flushing with saline and nitroglycerin will relieve the associated spasm. So the final take of my presentation is coronary physiology assessment with IFR or IFR is not only meant to be used in intermediate and simple lesions, but it can also help us to decide the procedural planning and to guide decisions in complex cases such as left mains, bifurcation, heavily calcified disease, diffuse diseases. Pitfalls related to technical and hyperemic agents should always be kept in the mind and should be taken care of. Post-PCI low FFR values are not rare, and they predict long-term clinical outcomes. Thank you.
Nice case demonstration, Dr. Libby. You showed all the category of the cases in which, tandem lesions, calcified. Just one case, the anomalous RCA. It was giving collaterals to the LAD, which was there. So do you think how these collateralization to the other artery, FFR, can be affected of the feeder artery?
Yes, ma'am, definitely collaterals can actually, if in presence of collateral, if your myocardium is getting supplied by, the distal myocardium is supplied, then FFR will not actually be affected, but it will show the true values, how much does it hold.
So sometimes, when you have a good collateralization, you're supplying a big myocardial area, so you get a false positive FFRs because the FFR value comes very low in these cases. So it comes to FFR value is not rightly measured in these cases.
It was not giving that much collateral, and we had already devascularized the mid-LAD.
That was pre, which FFRC did. It's basically for discussion that if it is collateralizing the other artery, then the FFR should give a false positive cases at these. Nice presentation. Any more question?
Nice presentations. I want to ask regarding the role of physiological measurement in post-PCI cases, like we are dealing with heavily calcified lesions where we are not achieving the optimal parameters. Then how FFR is going to help us in to know the success of the case and whether this result is going to help our patient in future physiologically.
It can, ma'am, if we are dealing with diffuse heavily calcified diseases, then FFR might not be optimal post-PCI, and we have to accept that at certain situations. It can help us to prognosticate patients and probably intensify the medical management in these cases. Otherwise, yes, the lesion, the clinical outcomes, if FFR is low, they are worse than those who achieve an optimal FFR post-PCI. But in those patients where we cannot, make the results any more better, then we have to accept the result and probably prognosticate the patient accordingly.
Okay. I think in calcified, if you know that your pullback comes very handy in these cases. You can do a pullback where you get a maximum drop. So you can have that this area have to address it more. So you can go for a high pressure balloon or an OPN at that point so that
and then they get a rerun with this. So if you can pinpoint which area is causing more problematic in these cases.
But once we have treated, the FFR might still be low. Once we have treated every step up or the modifiable factors, the FFR might still be low in those patients.
But I find challenging guiding the optimization based on physiology, because if you do a calcific lesion, we know by the studies your expansion is going to be 75, 80%. Even the studies with IBL, which is the best device, like the mean expansion was like 74%. So I find very challenging just doing a pullback and say, no, I'm going to optimize here that I see the chip, because you don't know exactly what you're dealing with. So what if you use an oversized NC and you had a perforation because you don't understand? So there are some studies ongoing, the defined GPS, but I suspect it's going to be very hard for them to show that we all have to achieve physiology over 0.95 in the PCIs, because I don't think it's possible. So I find myself uncomfortable guiding post-PCI, the optimization with physiology. If you don't understand if it's underexpanded, you had geographic miss, that will be better targeted by imaging than by physiology.
Thank you. So I think next talk is by Dr. Seko, which will be a woman, do they do better with imaging and physiology guidance?
Okay, before my talk, I want to introduce myself because you don't know who I am exactly. So, my name is Saiko Takahashi. I'm from Kamakura, Japan. And I have been working with Dr. Shigeru Saito, who is famous for transradial intervention and PCI for the chronic total occlusion for more than 20 years. Now I'm working at the Kamakura Hospital and two different hospitals, Kamakura and Oise Hospital. So Kamakura City was old capital in Japan about 1,000 years ago. And we have Buddha and beautiful shrines. And you can see Mount Fuji from the beach. And since Kyoto is far from Tokyo, Kamakura City is located just 1 hour by train from Tokyo. So when you come to Tokyo, you are welcome to come to Kamakura. So I want to talk about a little bit about J-Wink. J-Wink is the Japanese Women's Interventional Conference, which was established by in the picture of two pioneers of female interventionalists, Dr. Hoe and Dr. Tsukahara, in 2008. The aim of J-Wink is to encourage the female doctors to be actively involved in the PCI and to improve their skills. Consequently, our mission contributes to patients and our society. I think this aim is exactly same as WinCars. So we have done, we have organized activities, and we organized a session and gave a chance to the young female doctors to be chairpersons and moderators, and also opportunity for the live demonstration. And we invited famous female interventionists from abroad, and also we organized a workshop. I think also this is exactly what you are doing here today by WinCars. So I go back to my talk. So how do you treat this patient, 67-year-old female with hypertension and hyperlipidemia, came to our hospital due to the effort angina. There's a severe stenosis in diagonal branch, so maybe that's the curved lesion for this effort angina. But there's a stenosis, but severe stenosis in distal LAD. So So the lesion LAD looks like a 90% stenosis, so it's simple lesion, do PCI or do FFR, and you will make the decision, or do IBUS, or it's located in distal LAD, so we treat this lesion by optical medical therapy. So what we did was we performed FFR angio, and that value was 0.85, so we deferred this lesion. So a lesion in women's coronaries are similar percent diameter stenosis by visual estimation, but they have a lower severity of percent DS by QCA, and in IBUS, they have smaller minimum lumen areas, smaller plaque burden, and less severe area stenosis. But however, women's FFR showed higher than the men. So let's see the relationship of women and physiology guidance. This is a study from China, and they investigate the sex difference in PCI, physiology guide and IBUS guide, PCI. And there was a sex difference in the PCI rate in physiology guidance. A lower PCI rate was observed in female patients than that in their male counterparts. This is because difference was mainly contributed by patients undergoing FFR guided PCI. So there's a concern about the outcome of the woman who was deferred revascularization. But the data shows that target vessel failure of women in physiology guidance is lower compared to men, while target vessel failure was similar, both women and men in the PCI group. So same result were reported by several papers, and this is the data from Japan, and significantly lower event rate in women compared to men in patients with deferred revascularization. So let's see the relationship women and IBUS. We have a debate, so we know a lot about imaging guide PCI, but usually IBUS guide PCI has a better outcome than the angiographic guided PCI, because when your stent is optimally open, well, so the prognosis will be better. So in Japan, as I said, IBUS is covered for all the patients, but it's not like 100% use. In 2017, 90% of PCI IBUS was used. Unfortunately, we don't have data of OCT right now. So this is an interesting finding from that paper. The proportion of female patient is higher in non-IBUS group compared to IBUS group in regular PCI and emergent PCI. I was surprised that in Japan, women is equally used, IBUS was used, but I was surprised that the proportion of female patients in non-IBUS group was higher. So the non-IBUS group was older, the patients were older and with a higher proportion of females, and they have comorbidities and severe presentation of status at admission. As Dr. Mamas mentioned that if doctor don't do IVUS for the simple lesion, and but actually angio-guided PCI had smaller stent lumen. So how about OCT? So this is Dr. Maihara from New York. She said no significant difference with OCT and IVUS guidance were found for stent expansion. And Natalie said, give a lecture, mini lecture for us. OCT gives us a lot of information in terms of lesion morphology, such as stent malposition and tissue protrusion and knee dissection. And this is a report from Japan, and there's a gender difference in clinical outcomes with OCT-guided PCI. If patient is young, the graph A shows that incidence of MACE is lower in women, in younger patients who are under 70, while elderly patients, there was no difference between women and men. So this is a summary. In physiology guidance, women's FFR was higher and their lesions were often differed, but outcome of women in the differ group were better than men. Non-IVUS group in Japan had a higher proportion of women. I think there are reasons, but there's no data for the outcomes of the women in non-IVUS group. OCT gives us more information of coronary morphology compared to IVUS, and its use for young women might bring better outcomes. However, we don't know the real-world use of OCT for women. So imaging for women could be our future research topic. Okay, but
Very nice.
I want to say more. So thank you, Sarita. Always you inspire me, and Dr. Sujata, thank you for your warm hospitality. And I think collaboration between J-Wing and WINCARS are crucial for Japanese interventionalists, female interventionalists. Thank you for your attention.
Thank you, Dr. Seiko. Very pertinent topic. I think women are underrepresented in your study also. And if we see the morphology, we really don't have a very big data that do women have a different plaque burden or different morphology of plaque. Because we, in our Indian population, we are now seeing very young women coming to us with only diabetic, premenopausal women, and coming with ACS events and all. So we have to have a plaque. The one question, like, do you find that these intravascular imaging, do they show a different artery size in women? Other sides, artery diameter is smaller in women as compared to men? When we do that according to body surface area, or indexed artery diameter is same, or is they have a smaller artery diameter?
Sorry, because your voice sounds
so... she just wants to know that women, the size of the arteries on imaging, was it smaller?
Yes, it is.
So like we did one study from our institute, an IVUS guided study, like a retrospective analysis, in which we compared about 400 patients of proximal LAD and left main. So the diameter of the women was definitely smaller, but when we indexed it to body surface area, it was equal to the males. So it may be the build of the patient which decides the diameter of the coronary arteries. So maybe the women are more smaller in build, that leading to a smaller artery diameter.
Dr. Seiko, I found your talk very interesting. Okay, and when we see a different perspective from a different country, it makes it very interesting. And what I particularly found interesting was your last slide. It brought out so many differences, and there's so much space there for work. So a couple of things that you mentioned. you showed a slide in which you said that, you know, when you used OCT in younger women, it improved your outcomes. But you used OCT in older women, there was no difference. So according to you, why do you think, because you in Japan image a lot, so why do you think that difference is there?
I read the article, but it didn't mention it, but I think the number is small, so we really don't know. And I try to find studies compare the outcomes imaging PCI between men and women, but it's really difficult to find the result, and I don't know the reason, but
that was something that,
yeah, something
because
maybe we need to find.
it was very interesting because overall we've been talking about imaging a lot, and overall we even had a debate about imaging, and everybody was of the opinion that if you image, you end up with better outcomes. But here we see that it could be age specific also, because what you showed was that in younger patients, if you're imaging, you're doing better, and in older patients, we're not doing better. And when we think that it's normally the older population who would have the more calcified lesions, the more diffuse lesions, the more multiple stenosis. So in spite of that, we don't know why.
Yeah.
So that's a very interesting food for thought. Is it age specific? Is it older versus younger population? Is it male versus female? We need to think of both.
Yes.
So I have a question. So based on your data from Japan, do you suggest a different cutoff for women for the MSA or for the MLA for that matter in the left main? Do you guys have a separate criteria?
We don't have it.
No,
So we
it's
don't
the same.
So same.
It's the
We
same.
don't know, but there's something over there, but we don't have data, so that's interesting. Maybe different. Maybe
You-
the same. We don't know.
Point is very important, Dr. Sujata, because we know that Asian population, Asian ethnicity has a lower body surface area, probably lower size of the vessels
Yes.
also. So maybe we need to have data about different cutoffs for our population.
Also FFR, no different cutoff, same cutoff. So maybe you could rise the cutoff a bit. No.
Hello.
Because the rate is higher. I don't know.
Thank you, Dr. Siko. Amazing talk. And I think all the talks were also talking a lot about physiology, which is a way forward for deferred stenting and for
So thank you so much for the invitation to give this talk, which is the OCT, the game changer. And I know you're thinking why the Mona Lisa is there, but you're going to see why it is there. Looks like the audience needs like a coffee or a Cheers app, so I'm going to share my story, and then I'm pretty sure all of you are going to wake up. So who is Natalia Pinilla? So I told you this morning where I'm from. So because I'm from Colombia, I am like a Latina, so I always feel like this, wearing like a light dress, being in like a nice weather. But you know, this is the way I feel inside, but in Canada, I live like this. So I had to wear like a very heavy coat and have my hair covered. You see the Canadian flag in there, so this is how I have to go. But remember, this is the way I feel inside. So I feel like I had to bring the sunshine inside me because Canada is very cold. So more importantly, this is my house 2 weeks ago, and this is how much snow it was in my backyard. So thanks so much for inviting me, because at this time, coming to a beautiful place like this is just a blessing. So I'm feeling like back to my culture, just feeling this heat in my skin. This morning I told you that I went to Canada, and many of my mentors are actually from India. So in this picture, you see my amazing team. So actually, I work with Salim Yusuf, which is one of the most famous Indian cardiologists like around the world. And in this picture, there are 5 people from India, and 2 of them, Shamir, Mer, and Tej, are my mentors. So actually, I am the creation of 2 amazing, brilliant Indian men. So I feel there is a lot of connection in myself and my career with you guys. And this is why they invited me to this talk, because if I had just one eye, I will have an OCT eye. So I'm going to tell you how the OCT is the game changer. and why I love this intravascular imaging technology so much. So I think in the next 10 minutes now, I'm going to discuss what is important about the OCT in diagnosis and PCI, recognize the role of OCT in situations where the high resolution is needed, and acknowledge the artificial intelligence that has been incorporated in this technology. So as the background, I think we all know OCT is the intravascular imaging technique with the highest resolution, and is 10 times higher than the IVUS. We know now with the high definition IVUS that got closer, but still the OCT has a higher resolution. And this is the closest we have been to histology. So once the OCT came in our practice, we were able to describe so many mechanisms and findings in the coronary arteries that we were not able to do in the past. And importantly, this technology was the first one that incorporated so many automatic tools in plaque morphology, stent apposition, stent expansion that really benefit our practice every day. So the main differences of these two technologies are that IVUS it has compatibility with the blood, so you don't need contrast, and it analyzes very well the plaque burden, the positive remodeling, so it's helpful in left main, osteal disease, or vein grafts. But I think we have to acknowledge that OCT has such a high resolution that is better assessing thrombus, ruction, erosions, dissections, stent apposition, expansion, plaque protrusion, and a big benefit from this technology is the calcium assessment. So what it is so nice, this technology, you get to see so many phenomena in the intracoronaries that we cannot explain by other technologies. So we see early phases of atherosclerosis where only the intimal is thick compared to when it advances in the real plaque. So the fibrous tissue looks very bright. The calcium looks like kind of dark appearance, and you see very, very sharp borders. So identifying the calcium by OCT is much easier. In IVUS, we just see some shadowing, but all of these characteristics of the thickness and the expansion, we see it better with OCT. And here, just to show, you could see deep calcium around 10 o'clock. You can see very thick superficial calcification, but also the definition of non-eruptive and eruptive calcific nodules is much better with OCT compared to the IVUS technology. And this is a game changer as well. Like by IVUS, we cannot describe the fibrous thickness of the vulnerable plaque, so the lipid looks kind of dark because the attenuation is very high, but only with OCT we were able to describe the thin cap fibroateroma, which is very, very thin fibrous cap, and this is the main reason why the patients have plaque ruptures in an acute coronary syndrome. And not just that, but we are able to see macrophages, microvessels infiltrating the plaques, like cholesterol crystals, which is a very advanced stage of atherosclerosis. So we get to understand so much. Basically, we do OCT, and in our mind, we could describe how long this patient has had atherosclerosis for. Not only that, but this technology design that this was shown in a presentation earlier in this session, and then OCT was able to put these pullbacks and incorporated the lumen profile and put it in a roadmap in the angiogram. So this is a game changer in our practice because once you plan the procedure, you could display this lumen profile in your angiogram and plan your procedure very well. So I think this is a very important picture why OCT technology is beyond now compared to other imaging technologies, because the lumen profile, the top yellow profile, the OCT is like, it made us like a cartoon, so it's like straight out the vessel, and did so many areas in each cross-sectional image to be able to reproduce this cartoon, and based on this cartoon is where we plan our procedures. So this is a game changer because before this we couldn't have this 3D dimension put in a cartoon that is so easy to plan. So just explaining all of that, I wanted to bring 4 cases from female. I have 5 minutes still. And showing you what it is important to have a high resolution technique compared to IVUS in many situations. So
The first woman, 52-year-old female with all risk factors, family history, and she presents with an non-ST segment elevation myocardial infarction. The second woman, 45-year-old female, depression, anxiety, hypothyroidism, and the same presentation. Both had similar troponin elevation, both had similar LV findings with anterolateral and apical hypokinesia, and then by angio, I only saw two images at the ostium of the LAD, both. In the first case, some haziness, like a smaller lumen at the ostium of the LAD, and then in the second picture that is harder to see, there is also some haziness in the ostium of the LAD. So how do you know which one you have to do some dual antiplatelet therapy? Probably in both cases we are going to avoid stenting, but how strong do you feel to do dual antiplatelet therapy in one or the other, or both of none? So honestly, I had to say and disclaim that the first case, I was thinking that was going to be a plaque erosion with some thrombus at the ostium of the LAD. And the second case, I felt it could have been a Takotsubo or other presentation. But then when I did imaging, I realized that this angio, which is actually kind of confusing, you see a very tiny branch that goes across this ostial LAD. So you see it right here. And that little branch by angiogram was giving me the impression that was a stenosis, but actually it was not. In all of these images, you see how there was no thrombosis, there was no plaque disruption, it was minor fibrous plaque, and the minimum lumen area was preserved. So actually, this patient was the one that ended up having a Takotsubo. No dual antiplatelet therapy was used, and this patient had a repeat LV angiogram, an echocardiogram 1 month later, and this patient was a Takotsubo. Compared to this one that didn't even have clear cardiovascular risk factors, and you see clearly how has very extensive fibrofatty plaque with intracoronary thrombosis, with a smaller lumen area. So this one was the one that really had a plaque erosion, looks like, compared to the other one. So this is the one that was going to benefit from dual antiplatelet therapy and from a real treatment. So in these cases, you need the resolution of OCT, because in IBUS, you can now see the intima very well, or the luminal thrombosis with this definition. And then let's do these two cases before my time is over. 49-year-old female, first case, NSTEMI, family history of CAD, and almost the same angiographic image in a 31-year-old female with NSTEMI and no cardiovascular risk factors. I had to say one of these ended up having a stent, and I want you, raise your hands if you said I put a stent in case 1 or 2. Who says I put a stent in case 1? Just raise your hand. Yeah, very good. And who says I put a stent in case 2? So did I put a stent in both? I had the same people raising the hand for both. So maybe both needed a stent, so we are gonna see. So this was a lot of learning from these cases, because in this second case, you see how the apical LAD is so tiny. So when I saw this case in a 31-year-old, I say, oh, this has to be a spontaneous dissection, right? She's 31, she doesn't have risk factors, and the apical LAD looks this small, so this was easy. I had to confess both of these patients were thought to have a spontaneous dissection, so none of them had imaging in the acute setting. Both stayed in CCU, and imaging was performed later when we didn't feel there was a risk of progressing the intramural hematoma, if that was the case. But the first patient had been very symptomatic in CCU, and she required a second angiogram, and at this point we needed to make sure what was happening, and this was a clear intramural hematoma. You see beautifully how the layers separate, and you see this like a moon-like shape of the intramural hematoma here. So this patient was treated conservatively. And this 31-year-old with no risk factors had terrible fibrofibrotic plaque, 360 degrees with a very small lumen area. So she had a CT scan, and the apical LAD was an intramyocardial bridge diffusing the apical LAD. So again, this is why we need a high-resolution technique in these cases to make sure what we are dealing with. So not only that, but before my talk finishes, now OCT has launched the Ultron 2, and the Ultron 2 is just gonna change your practice. I saw there is a booth here for Abbott, and in this one, I think Dr. Mirbad used the Ultron 1 for her case, but in this Ultron 2, you had a clear definition of this orange ring that is gonna target your calcium, and also you have this white line here showing you where you have external elastic lamina. So planning the procedure is so easy. You know where your calcium is, where your external elastic lamina is, and planning the procedure is much easier. Not only that, but they developed this live placement of the stent. So you set up your lumen profile with your proximal and distal landing zones, and the angiogram gets incorporated in the OCT, and while you're putting your stent, you basically see your markers and where you're gonna put your stent. So this is gonna avoid contrast, radiation, and everything during the procedure. And also the post-PCI assessment, expansion, malaposition get beautifully displayed, and you also have these compare pullbacks that you are able to see the pre and post in this software. So this software is actually a game changer. Once you start using the software, you're even gonna love more OCT. So why did I hack the Mona Lisa? And sorry, my slide gets cut off, but how do you want to see the Mona Lisa? Many of us, we have been there in this beautiful museum, and we are fighting with everyone, mostly with Japanese, where is Saiko, mostly with Japanese in order to get the Mona Lisa. So how do you want to see the Mona Lisa, how good or how bad? And this is where it comes. So do you want to see the Mona Lisa like this, by angiogram, like very, very blurry image when you get to see it from very, very far away? Do you want to see it like this, like a shadow that you are able to define a little bit better? Do you want to see it like this in black and white? Or do you want to see it like this with OCT? So you want to see it, you see, just by that, you wanted to see it like the OCT. So I think just by that, just as my take-home message, OCT is the highest resolution, and we have to acknowledge many situations will benefit from the high resolution. Acute coronary syndromes, vulnerability, calcification, stent failure, bifurcations, and the clarity, friendly console display, artificial intelligence that has been incorporated in these technologies is a game changer. So again, I'm sure you want to see the Mona Lisa just like me doing OCT. Thank you so much.
Thank you, Dr. Natalia. That was an amazing talk. And we all agree with you. We want to see the Mona Lisa with the OCT. We're very convinced with your talk. And even otherwise, we are all OCT users over here. And a lot of them are there in the audience too. And it's been a game changer. Because the clarity with which you see everything that you're doing, and even in the case which I was presenting in the morning, that your strategy changes when you see things from the inside. When you see what is the kind of plaque that you're dealing with, what is the upfront atherectomy device that you're going to choose. When you're doing a bifurcation, you want to see your side branch. You want to see if you've still got some struts left over there. Are you going to come back with a fenestrated restenosis? If you want to find out the mechanism why your stent failed. There's so many things in which OCT has been a game changer and changed the way that we interventionists performed, and has given us an insight into how to deal with our patients, made our long-term outcomes so much better. So we couldn't agree with you more. OCT has been a game changer. Thank you so much.
Yeah, so the next speaker is Dr. Zakia Khan.
Just a small reminder to the chair, we are running more than half an hour late.
I think, Natalie, when it comes to buying TV at home, people want high definition TV, color TV, smart TV. So when it comes to imaging, I think we all want OCT. My talk focuses on imaging in stent failure. As you all know that stent failure is higher with BMS and lesser with DES. And the predictors of restenosis, some of them are patient-related, some of them are lesion-related. Diabetic patients, CKD patients, prior vein grafts, ostial lesion, diffuse lesions requiring long lesions, long segment of stenosis, vein graft disease, small vessels are all more prone for restenosis. Some of the procedure-related factors being under-expansion of stent fracture, inadequate lesion preparation in de novo coronary lesions, calcification, all these predispose for undersizing of stent. When it comes to pathogenesis of ISR, it's a combination of neointimal hyperplasia, neoatherosclerosis, and mechanical factors like stent underexpansion or stent fracture, which can be very well seen with OCD. When a pattern of neointimal hyperplasia, if you see with DES, it is more focal pattern with DES and it is associated with a layered pattern with heterogeneous tissue composition. You have lipid foamy macrophages within the intima with or without necrotic core formation, calcification, which can occur as early as 3 months or many years later. So imaging helps you to identify the cause of ISR, differentiates between a mechanical mechanism versus a biological mechanism or a combination, and hence helps you to decide the strategy. Why OCD? IVUS is limited in its ability to evaluate neoatherosclerosis. It allows accurate assessment of lumen pathology and enables more detailed visualization of stent architecture and strata position. And of course, a reliable characterization of neointimal morphology. When it comes to classification of ISR, the older classification relied more on the angiography. However, this did not help you to decide what exactly is happening inside and did not help you to tailor the therapy. The Waxman classification is a new OCT-based classification where you have type 1, type 2, type 3, type 4, and type 5, and depending on the type, a strategy can be decided. So you can see if you have something like a mechanical underexpansion, stent fracture, or intimal hyperplasia. They all can be treated with a combination of high-perfusion balloon, DES, or a new cutting balloon. Whereas if you end up with more than 2 layers of stent, it is like stage 5. Then maybe a balloon, maybe laser, or sending the patient for CABG. Just presenting 2 cases. 55-year-old male with diabetes, hypertension, presented with unstable angina, moderate LV function. There was a history of PTCA to RCA 1.5 years ago, and the patient gave a definite history of DAPT compliance. He said, maybe I took the drugs for 3 months and then I stopped. So this is the way the artery looked when the patient came to us. His drop was positive. A long stent with a long, almost total occlusion of the artery. So we decided to do the imaging. Of course, the lesions were too tight, so passed a cyan blue wire, pre-dilated with a 2O balloon, and then passed the imaging catheter. You can see the image now. So this image shows you clearly a combination of neointimal hyperplasia, fibrofatty plaque, and a ruptured plaque in the mid-segment. The stent looked a bit undersized. It was 3 almost, I think the artery was looking almost like 4. So we decided to use a cutting balloon, 3.5 into 10, dilated well, post-dilated again. We then decided to re-stent this lesion in view of the stent going beyond the lesion, going beyond the stents. Distally, we used a 3.5 into 38, overlapped with the 4.0 stent, post-dilated 3.75 distally and 4.0 proximally. You can see the OCT run with good opposition and 2 layers of stent. This was the final result. Second case is a more complex patient. The post-CABG patient has CKD. There is a history of 2-vessel PTCA in the past, following which he underwent a CABG because there was a stent failure. And then he came back again with acute left ventricular failure, drop positivity, high pressures. We took some time to stabilize him with medications and then took him up for angio. You can see the angio. His left system was, left grafts were patent. The RCA graft was totally occluded. And you can see a long diffuse disease and predominant stenosis and calcium behind the stent. It obviously looked. You can see a totally occluded vein graft in this patient. So the patient had native left main with TBD, ISR in the mid RCA, distal RCA showed 75 to 80% stenosis. Graft angio showed a Lima patent and SVG to D1 patent, occluded SVG graft. Since the patient had severe hypertension, we also did a renal angiogram which showed a significant right renal artery stenosis. So we planned the case with PTCA to RCA with plaque modification using a cutting balloon. We said we'll be ready with IVL and imaging as IVUS because the patient was a case of CKD. And we'll do a stage PTRA to right renal artery at a later date. So the RCA was engaged using a 6F-JR. RCA lesion was pre-dilated with a 2.0 balloon. And then IVUS was done. We had at that day Volcano available with us. And this clearly showed that we had chunk of calcium remaining behind the stent. So then when you have a significant calcium which is behind the stent, we have only 2 modalities. Either we do stent ablation, which is a more morbid procedure, or use IVL. So we chose a safer procedure and used IVL. So use shockwave, delivered shock at multiple sites, especially more at the stented site. The distal lesion was dilated and stented with 2.5 into 32 synergy. And proximal was stented with a 3 into 48 Zions expedition. Post dilated with 3.5 into 12 NC balloon. And this is the final result. Final IVUS imaging. With good opposition of the stents. We got good MSAs. So my take-home message is with these 2 cases that imaging should be considered in all cases of ISR. Of course, OCT gives better insight into underlying pathology of ISR, mechanical versus biological versus mix. and eventually translates into choosing exact modality of treatment and improve the outcomes. IVUS is preferred over OCT in CKD, osteal lesion, left main. And of course, if you are trying a CTO-guided IVUS lesion re-entry. And mind you, with drug-coated balloons coming up more, I think we should decide what to stent, what to leave behind, and what could be treated with drug-coated balloons. So I think we should be judicious while treating coronary artery disease, especially with restenosis. And if you can achieve a good lumen, use drug-coated balloons if you have existing stent. Thank you.
Thank you, Dr. Zakia. That was a nice talk. Coming back to drug-coated balloons, like where would you want to, I was wondering whether you could use drug-coated balloons in some of your cases.
In the first case, I think the stents were undersized. Secondly, the disease had gone way beyond the stents, proximally also, distally also. So in this particular case, and we were not able to get very good, results even with adequate balloon dilatation, cutting and everything. So I felt that putting a bigger stent would give a better answer. So in this first case, we chose to use a bigger stent. And using drug-coated balloon, I think currently I would use more in smaller vessels, long lesions, distal LAD long lesion, or you make kind of a hybrid approach. If you have a LAD that is diffusely diseased, maybe proximally you stent, distally use a drug-coated balloon. You could use it in a side branch of a bifurcation disease. So I think these are some of the limited indications where I would use right now, because I think we don't have very strong data to start using it in proximal arteries, big arteries, because we need, I think, more trials to say that I can use it in osteal LAD, I can use it in osteal RC and sit on it, and many times the artery would close. So I think we need to have more guidelines, more trials to use drug-coated balloons and real hard guidelines.
I think many of us have tried using it for osteal circumflex as well, and it works pretty good. Dr. Natalia, I just wanted to ask regarding between if you have a neoatherosclerosis and just neointimal proliferation as part of the pathology for restenosis, what is your approach?
Yeah, I think neoatherosclerosis is the only setting that we prefer to use a new stent, because that means the healing and the controlling the blood was not appropriate. But if you have clear neointima, our approach is cutting balloon and drug-coating balloon after. Yeah.
I think imaging is essential in stent failure, and we decide the strategy as rightly pointed on your cases, and very well presented with 2 cases. Thank you, ma'am.
Thank you. Thank you.
I think we can close the sessions, and we thank all the speakers and the audience for the interactive participation for this. Thank you.
The next session is Modern PCI Symposium. I would now like to request the chairperson, Dr. Ajit Mullasari, Dr. V. Sujata, moderator Dr. Sarita Rao, expert panel Dr. Hemarath, Dr. Asha Mahilmaran, Dr. Richa Sharma, Dr. Mahapekar Mashadi onto the stage. Our first speaker is Dr. P.K. Saho. He'll be talking about pre-PCI assessment using IVUS, how it defines PCI strategy.
So I think Sarita has gone to get us a cup of coffee too. So I think this modern PCI techniques are catching up. So none other than Dr. P.K. Sahu, who is a very interesting speaker. He's got lovely cartoons in his slides, and see, as I said, thank you, sir. You can go ahead.
Thank you. In fact, if you ask me what was 2023 important for, I consider it as a year of imaging. whether it's IVUS or OCT, since morning I am seeing that everyone is telling about OCT. And in this crowd, mainly they are all the beautiful females. We are only the males, so the IVUS has been given to us. So that is, I start with. Supposing your father would have deposited 1,000 rupees balance in your account, and then you go to the cashier, he'll tell you, see, your father hasn't deposited. So what will you do? You'll just try to see, poke your head inside and see whether he has really deposited or not. That is where IVUS comes. That is your accountant in the bank may be speaking something wrong, so you have to better to confirm it before jumping into it. So I'll speak on pre-PCI IVUS assessment using IVUS, how it defines PCI strategy. In fact, I have been using IVUS for more than 10 years and OCT for around 6 years. So I consider IVUS as my wife and OCT as my girlfriend. Now, the thing is that when anyone sees the first picture, this gentleman, when he sees the coronary artery, he's, dude, I just see a hole. He doesn't realize anything what's going on. But then, when you do an IVUS, you'll see, you'll do better than an OCT, which I'll prove in my slides. Number one, what is the plaque morphology? Number two, does this plaque need modification? And number three, how to size your stent, and I'll show some real life scenarios. What is the plaque morphology? IVUS interpretation is very easy. Basic plaque, 3 types: soft or fatty, fibrotic, calcific. Complex plaques, 5 types: dissections, plaque rupture, thrombus, erosion, hematoma, true false lumen. The whole IVUS surrounds this. Now you see, these are the various types of plaques you'll get. Either it's concentric, eccentric, soft plaque, fibrotic plaque, or calcific plaque. Very simple, 5 types of plaque. Don't go beyond that. And now when you see from black to white, very easy, either it's fatty, it's fibrous, or it's calcific, or maybe fibrofatty, or maybe fibrocalcific. So it's so simple to interpret IVUS. It's not very difficult. And next, or a mixed plaque, which is a mixture of everything. Like now these political parties are mixing everything, so that is true. Now coming to the complex plaques, you'll see there will be 5 types of complex plaques. Either it is a dissection, a rupture, a thrombus, a hematoma, or true false lumen. So these 8 types of plaques, if you remember, your IVUS story is very simple. Nothing more to do more than that. Dissections, very easy to identify. If you're using a 60 megahertz IVUS, I've worked with a 20, 40, 60. I have 3 IVUS machines in my cath lab, but 1 OCT machine. I depend more on the IVUS. ACS evaluation, always they tell that plaque erosion, plaque rupture is very easy to identify on an OCT. I differ, because you see, we know, the first picture is of an erosion, next is a rupture. Why? I'll show you. In a rupture, it is very easy to identify if you try to see, because we all like colored images. We don't like black and white images. But nowadays, the pictures that you see the hero is shown in black, there's someone shown in colored. So it is something that the hero is always shown in black. Now, supposing you see here is the plaque rupture. See how easy it is to interpret. So this is a pre-IVUS imaging, and I know that I have to stand this because this is a plaque rupture. Next, when I go to a thrombus, it is very easy to identify the luminal that you will see, that is a thrombus. And here I'll show you the HT IVUS showing how it is a plaque erosion. Here you do not do anything, just go put him on medical management, put on all your GP2B, 3A, thrombolytic, whatever you want. Next, if you have a hematoma, it's very easy to identify. Of course, this is a 40 megahertz. I'm showing you cases from my real life scenarios, and that is what I'm doing. True false lumen, very easy to identify. And doing a OCT in a true false lumen can be suicidal, because you might dissect the full thing and you might cause more problems, which I have also done. Next, does the plaque morphology need modification? You do not need an OCT to know whether you need modification. Very simple. If it is very black, it shows soft plaque. If it is very white, it is calcific. So if it is very black, just pre-dilate with an NC balloon. If it is in between white and black, use a cutting balloon or an NC balloon. And if it is totally white, you have to use something like an atherectomy or an IVL. Now, quantify it, whether it's superficial, deep. This is where people start telling me, is it deep calcium or superficial calcium? Very easy to know. The IVUS calcium score is there, which is ratified, and it has been shown that you have to see what is the angle of calcium, what is this thing that is degree of calcium, whether it's a nodule, or what is the vessel diameter. So I'll just take, it has been shown that in calcium scoring, if you do it properly, your stent expansion is good. I'll just take an example. For example, here the circumferential calcium give 1 point, there's a length give 1 point, vessel size 0 because it is more than 3.5, calcified nodule 1. So the total score that comes to is exactly 3. That means you have to do advanced preparation. It is as simple as that. No contrast, nothing, just take multiple runs, be confirmed. How bad is this calcium? Just see the calcium, see the reverberations. This reverberation indicate one thing, the calcium is superficial, don't go for your IVL. So you see it can be luminal, it can be deep, it can be 180 degrees or it can be concentric. These are the various types of calcium we'll see on IVUS. Now it has been shown that if the reverberations are there, studies have clearly shown that you don't have to go for any high-end modality for your calcium, this thing that is debulking. You use a simple modality. A cutting balloon is more than sufficient, and this has been documented in studies. Next, as you see the calcium becomes thicker, the reverberations will go away and you will not see. So based on the reverberations, it is very easy to identify whether it is a thick calcium or is thin calcium. And most importantly, you can also know whether your strategy of doing the procedure debulking is good, because in ROTA you can know what you have done, in IVL you can also know what is done. Now next is how to size your device. 3 steps. The third step is how to size your device. Very simple, you just try to size it, balloon 0.5 millimeter average, see the proximal and distal diameters and just take 0.5 millimeter. Cutting balloon, average of again the proximal distal. Stent, again average of the proximal distal. So it's very simple to do it, and this is a very important thing because here angio might fail but IVUS helps. Now for example, you have to see the length. You see the length, you take the 2 markers and then you see what is the size and you take the length. As simple, because the longitudinal view will show you everything. Next, about how to measure the vessel size, you go to the distal and the proximal, make an average and then finally take the length size, take the landing zones, and know that you have to land the stent at a stenosis which is less than 50%. It's as simple as that. Stent expansion has been easily documented on IVUS. Now, you can be very aggressive by going from lumen to lumen. This is the least aggressive. You can go from media to media, which is midway, or you can be very aggressive by doing the maximum dilatation to see that you achieve the most. Next, how to measure stent expansion? You have to see that at least 90% of the proximal and the distal is expanded. So whatever your pre-IVUS showed, try to achieve 90% in the proximal and 90% in the distal. For example, in this proximal expansion, it was 9.71, 9.69. So that is how you finally get your results. Similar distal expansion, 5.52, 5.01. You don't just have to go on dilating. Just calculate it, get 90%. Some real life scenarios, LMC shaft. Now what you see is LMC shaft, if you see it, this is a very fibrotic lesion, and what I could do was just escape with a cutting balloon, and I didn't have to do anything much because you don't see any calcium anywhere. Just use a cutting balloon, NC balloon, and you can escape. Now, for example, in an osteal disease, in this osteal disease, you can see the osteal LMC disease. So here you see a little bit of calcium around, nothing more debulking required. You can use a cutting balloon or an NC balloon and you can get a good result. Next, IVUS in bifurcation. I think this is the most important because you have to know what you have to measure in IVUS. The stent angle, this side branch, everything can be easily known. And most important, what you people say, the eyebrow sign, which is very clearly visible on IVUS prior to stenting, and you can know that whether you're going to pinch the side branch or not. One important thing when you do a bifurcation, it is not necessary that you have to go to a deep study to do all an OCT and everything. But this was a case of decay cross which I've done, and you will see that at the end you can see the carina, which is very well visible on an HT IVUS, and you can see the proximal and the distal and both the side branch and the main branch, and you can know whether you have done it properly or not. If you compare the OCT and the IVUS, they're almost comparable. I'm not debating here about OCT or IVUS, but this is what to show how IVUS is helpful in a bifurcation lesion. Now, this is very important, which can be detected only on IVUS. That is, whether there is if you somehow sacrifice a side branch, you have to know whether it's a plaque shift or a carinal shift. The management of a plaque shift or a carinal shift is very important, and you can only know by an IVUS. And it is very important to know that a shifted plaque has a different strategy than a carina. Now what is it? If it is side branch plaque, which is this thing that is troubling you, just go for a light pressure with a high pressure with a large balloon. But you have a shifted carina, just with a small balloon with a lighter pressure. Very simple tip, it works, don't put a second stent. And this is only detectable on IVUS. OCT doesn't detect it. Next, ST-IVUS, calcific lesions, very calcific lesions, no reverberations, so this is a thick calcium. Then I used lithotripsy. You want to see the lithotripsy cuts? So beautifully seen. I think it is better seen than OCT. That is what I would say. Next, this is a case of ISR. But my previous speakers have told that ISR is well seen in OCT. I agree, it is seen. But IVUS, 60 megahertz IVUS is nothing less, because if you see this OM which was intervened 2020, this was the pre and post, and then if you see that, what was the plaque morphology? It was just a fibrotic lesion. You just take NC balloon, dilate it, and then finally you see the results. It is very good. Stent failure, for example, I think the images are not moving. This was done in a previous center. They never used any imaging. There was no pre-dilatation. They did a direct stenting. And the patient came to me after around 1.5 years or 1 year with this condition where the stent is totally stenosed. And what we had to do was basically do an IVUS, and so there was intimal hyperplasia, there was a ring calcium, and was not opposed. The process is very simple. Just dilate it with a larger balloon, and then you say a good result. Possibly you can use the DEP over here, and that was done. Next, if I have to conclude my talk, I have to say 2 buffaloes watching a log or a bit of wood over there. One says angio is enough. The other person says IVUS is needed. So then the first person is very confident and he tells that it is nothing. He goes down, nothing, but there is a crocodile who starts eating the buffalo and the buffalo is gone. And then this next buffalo says, no, I need an IVUS now. So this is the role of IVUS in doing a pre-assessment so that you can know that even if the Mona Lisa is black and white also, it looks good. Thank you very much for your patient hearing, because you'll see this is just a pre-assessment. Thank you very much.
Thank you, Dr. Sahu, for that very interesting and amazing and informative talk. I think what is very important is that imaging. In India, most of the centers have one or the other. There are very few centers which have both the imaging modalities, but we all agree that imaging is the way to go forward, and it does improve all of our outcomes. Each modality has some advantages in some way, and also each modality can be used to circumvent the problems which are there. For example, when we say, IVUS is better in osteal and IVUS is better in CKD patients, but then OCT users have found way to do IVUS in osteal left main using a telescope, have found ways to do a saline OCT and do it in CKD patients. And IVUS has its own advantages, especially in sicker patients when we don't want to use that forceful injection, and we do use that. And there are many things which are seen beautifully on IVUS, many things seen beautifully on OCT. But ultimately, imaging does help us to improve our outcomes. Any questions from the panel? Thank you, Dr. Sahu. Amazing talk. We'll now move to our next presentation, that is the case in box by Dr. Preeti Sharma from Max Hospital, Dehradun. opportunity. And it's taking time. Yeah. Shall we do it? Yeah, I'm sorry for the delay. So we are having a little technical issue right now, and while we solve that, we'll move to our next presentation by Dr. David Rosario, Rotacut, the cutting edge for calcium treatment.
Thank you so much to the organizers for giving me this opportunity. It's really a pleasure and a deep honor for me to present today. Can I have my slides?
Technical team, can you please put up the next presentation of Dr. David Rosario?
So my topic is the rota cut, that is a combination of rotational athermy and cutting balloon in calcified lesions. The concept is basically that if one does rotational athermy followed by using cutting balloon, one may actually get a larger lumen gain compared to just using rotational athermy followed by a conventional non-compliant balloon. So that's the concept. Whether it works or not needs to be seen. So I would just like to go through a few studies. There are not a lot of studies, but there are some studies where this rota cut strategy actually has been used. And probably the latest one of them is from Mount Sinai, Dr. Shamin Sharma et al., where they actually used rotational athermy with cutting balloon in moderate to severe calcified lesions versus rotational athermy followed by non-compliant balloon. So this is what they did, and the endpoints were actually validated by IBUS, and the final IBUS image was actually images were blinded to the primary operator. So what it was found was that combining rotational athermy with cutting balloon actually gave a similar minimum stent area. The MSA between the rotational athermy and the cutting balloon group was similar to the rotational athermy with a non-compliant balloon. However, there are a few points that needs to be taken into account. One is when the FDA actually approved this trial, what they said was you cannot go with a cutting balloon to more than 12 atmospheres pressure, because prior to this study, there was no FDA approval for the use of cutting balloon in severe calcified lesions. So they said you may use it in this trial, but not more than 12. So that is what actually Antonio Colombo pointed out, that perhaps had they gone to higher pressures, the results would have been different. Softer endpoints like there were more cracks actually. I was guided, I was shown there were more cracks in the rotational apnea with the cutting balloon than the rotational apnea with the non-compliant balloon. The stent expansion, which is actually the MSA divided by the mean of the proximal and distal reference diameters, areas, that actually the stent expansion actually was better with the rotational apnea and the cutting balloon compared to the other group. However, these were the secondary endpoints. The primary endpoint of MSA was not, and perhaps because of the lower pressures with the cutting balloon. So then this is a prepare trial, slightly older compared to the rotacut trial of Shamin Sharma. This actually is from Europe, where actually they have compared rotational apnea with cutting balloon and they have compared it with a modified balloon. And they found actually that the results are that you do get higher acute lumen gain and higher MSA compared with the rotacut strategy, and it's a safe and feasible strategy. Then this is actually a smaller study from China, where actually they have actually compared the same thing, rotational apnea with cutting balloon and versus rotational apnea with a normal non-compliant balloon, and where again they found that same thing. The results were that aggressive plaque modification can be safe and is feasible, and it does actually translate into better lumen area when you use the rotational apnea with the cutting balloon strategy compared with the rotational apnea with the non-compliant balloon. So, and this is another trial which actually shows a similar thing, where you get more fractures, better lumen gain when you use rotational apnea with the cutting balloon versus rotational apnea with the non-compliant balloon. So what we basically do is, now does it mean that I use cutting balloon in all patients where I do rotational apnea? Obviously the answer is no. So what we do is we rotablate, and once we've done the rotablation, we keep the rotor wire in place and we put a workhorse wire parallel to the rotor wire, and then we take a non-compliant balloon which is 1:1, and the 1:1 balloon actually has fully expanded at around 14 to 16 atmospheres pressures in two orthogonal views, which means that I actually am done and I can put a stent. Whereas if the non-compliant balloon has not expanded in two orthogonal views at 14 to 16 atmospheres pressures, it means that I'm not done, and I either need to upsize the burr at the rotor wire parallel so I can upsize the burr, or I can use the cutting balloon to get the job done. So that being said, I'll just show you one or two cases, I think, where we have done this strategy. So this is a 65-year-old gentleman who had come to us, who's a hypertensive and had undergone CABG 10 years ago, and had presented with reference angina class 2, which had come to class 3. And he had undergone Lima to the LAD, saphenous vein grafts or diagonal, ramus intermedius, OM of LCX and PD of RCA. ECG showed Q waves inferiorly, and there was inferior wall akinesia with an EF of 40% on echo. Now this is the angiography which was done in an outside hospital, and what it basically shows that surprisingly the Lima to the LAD was occluded, and the SVG to the PD of RCA and ramus intermedius were occluded as well, and the SVG to diagonal branch was the patent. So this is actually almost like a single surviving artery, and we have you can see there's a very tight, heavily calcific distal left vein stenosis. There's a very sharp angulation from the left vein to the LAD, which is also heavily calcified and critically stenosed. So this is what we are working with, and so this is how it looks. So what we did was we actually wired this vessel with a workhorse wire, and then we extend a rotor wire. In the second screen, picture you can see we are doing a rotation apnea with a small burr. It's a 1.25 mm burr. It's a little difficult, and then finally it does make the pass, and this is the final polishing run. And this is how it looks after the 1.25 burr has done the job. And after that, we knew 1.25 burr was not enough, so we've taken a 1.75 burr, and this again is finding a little bit of trouble to go in, as you can see, but it actually finally does make way. And you can see that it actually has passed. And this is how the picture looks after the 1.25 and the 1.75 burr has done their job. So then what we did was we took a 1:1 non-compliant balloon, which is a 3 mm balloon, and you see there's a waist there. And so we know that we're not done. And though we have used 2 burrs, there's a waist in the 1:1 non-compliant balloon. And so we knew we had to do something more. So we actually have taken a cutting balloon here. And the center picture actually shows a cutting balloon, which was good result. We did a cutting balloon along the entire length of the artery, left into LAD. And the picture on the extreme right shows that the results actually look quite good. So when we have this kind of picture, we know that we are good to stent, and so we put overlapping drug-eluting stents from the DES from the left main to the LAD, and you can see that the end results look quite good. This patient has been asymptomatic for quite some time now, and he recently also came for a checkup. He's doing good. So this is one case where we had. This is a second case. This gentleman actually was a high bleeding risk patient, and actually came with aortic angina class 3, and as you can see, heavily calcified, distal left main, very tight, osteoproximal circumflex calcified, osteoproximal LAD is even tighter. The osteoproximal LAD is heavily calcified and very, very tight. He had a absorbed BVS implanted previously to the LAD and a metallic DS to the LCX previously. Previously. So this is the iliocaudal view, which shows the calcium, the bilateral left main disease, the calcific, very tight LAD stenosis, very calcific LCX stenosis also can be appreciated. And this is the epicranial view. So what we did, what we basically did in this case was we wired with a workhorse wire, and we started doing rotational atherectomy with a 1.25 mm burr, with a 1.75 mm burr, I'm sorry. As you can see, the 1.75 burr is not crossing, and we've been at it for a while now. The guide catheter is coming out, the burr is not advancing forwards, so we know that the 1.75 is not crossing the lesion. So what we did was we downsized to 1.25 mm burr. Here also you can see the guide catheter is coming back, so the 1.25 mm burr is also finding it difficult to cross the lesion. So what we did was we upsized, we kept at it, and the 1.25 mm burr was finally able to cross the lesion, as you can see. Once we've done that, this is the picture of the 1.25 mm burr. The results looks better than before. And since we had already opened the 1.75 mm burr on the table, we took the 1.75 mm burr and did ablation. As you can see, the 1.75 mm burr nicely crosses the lesion and has done the job. And this is a picture after the rotational atherectomy with the 1.25 and the 1.75 mm burrs. So, and this is a picture in the RL caudal view. Looks better, but the job is not done. So after this, what we do is we wired both the vessels with the workhorse wires, and we took a cutting balloon this time, and we did a cutting balloon angioplasty left main to LAD. As you can see, the cutting balloon is in position. The cutting balloon has nicely expanded to the left main to LAD, and this is how it looks. Now the LAD looks really good. So we have seen this time and time again. If you do rotational atherectomy with a cutting balloon, you do get very good results. And then we did the same cutting balloon to the circumflex, nicely expanded, and this is how it looks. Now both arms look expanded. You can see there's a dissection on the left main to LAD on the superior margin, so we know the vessel is well prepared. We knew we would put a 3.5 mm stent in the left main to LAD, so we took a 3.5 mm non-compliant balloon just to make sure it is expanding well. And at 14 atmospheres, it is well expanded, so we know that we are now good to stent this. So I'll just skip the steps. What we did was what we usually do in our center is we do a step mini crush. We first position a stent in the side branch. We have a balloon in the main branch getting ready to crush the stent. We optimally position the stent, and we expand the stent. As you can see, that stent in the LCX is nicely expanded at around 14 atmospheres pressures. And after that, we've taken a picture. This, I think, is a very important step when you do either DK crush or mini crush. You take a picture after you implant the side branch stent, and if there's an issue downstream, you need to fix that first before you crush the stent with the balloon. So then the main vessel stent came in, and the main stent was deployed nicely, as you can see, at around 12 to 14 atmospheres pressures. We did a port. After that, crossing with a workhorse wire was very easy. Just a workhorse wire. Then we did a sequential high pressure dilatation of each arm, and the final kissing balloon at around 14 atmospheres pressure. This was our final results. So just wanted to illustrate a few cases that where we have used this combination of rotation atherectomy. This was image guided, and we do get very good lumen area at the end of rotation atherectomy with cutting balloon. Doesn't mean that you need to use rotation cutting balloon in all cases of rotation atherectomy, but if your imaging shows that there is not enough cuts, or you find that the non-compliant balloon 1:1 is not expanding, then you should upgrade to either you can increase the burr size, or you can increase the cutting balloon. Upgrading to a burr may be difficult, because if you want to use the bigger size burrs like the 2 mm burr, you require a definite 7 French. 2.15 will go to an 8 French. Also, if you're using the Y connector, the normal Y connector that we use for angioplasty That takes the 1.25 and 1.5 burr, but the 1.75 you need the screwing microcatheter, otherwise it tends to get trapped at times. That's what you find. So that's my presentation.
Thank you, Dr. David, for a very lucid presentation and excellent demonstration of the RotaCut technology. A couple of things which I wanted to ask you. One is, for the interest of the audience, I would like you to just elucidate how do you size your cutting balloons according to the lesions? So what size do you use in a normal vessel? What size you use in an ISR? So how do you size your cutting balloon?
So what in a normal vessel de novo where there's no ISR, what I usually do is I take a quarter size down, but a one size down. So the one size down is always not possible. Like for a 3.5 mm vessel, I would like to use a 3.25, but we don't usually get a 3.25 cutting balloon. For a 3, I will use a 2.75. For a 4 mm, I would like to use 3.75, but that's not easily available, so we'll go with a 3.5. So with a de novo lesion, I like to keep one size down. And with a Wolverine cutting balloon, we can actually go to higher pressures. So I go to around 16 to 18, up to 20 atmospheres also for de novo lesion, not a problem. With the older flextome, there was a problem. If you go beyond 12 with the flextome sometimes used to rupture. But I've not had any instance of rupture with a cutting balloon, with a Wolverine cutting balloon at 18 to 20 atmospheres pressures. For an ISR lesion, I will definitely go 1:1 and go to around 20 atmospheres again. You inflate the cutting balloon, keep it inflated for 30 seconds to 1 minute, so you get deep cuts, and then you deflate the balloon, pull it back, rotate and push it forwards so that your atherotomes are now oriented along different planes. The cutting balloons actually have got 3 atherotomes up to the 3.25 cutting balloon. The 3.5, 3.75 and the 4 actually have 4 atherotomes. And these atherotomes are actually 5 times sharper than a surgical scalpel, people who've done bench studies. So this is how we use the cutting balloon.
So that's a very interesting point which I wanted to bring around, and Dr. David has elucidated it beautifully, how we can reintroduce it, change the alignment and get more cuts. Now, one last question to you. You used a 1.25 burr, you upgraded to a 1.75 burr, and then you used a cutting balloon. Could all of this have been avoided by just going in with an orbital atherectomy?
When we had done this case, orbital atherectomy, the case that I showed, this was done in actually 2021.
So it was not available at that time.
At that time. And so we took a 1.25. So when I upsize a burr, rotational atherectomy will be preferred to orbital atherectomy. One could say that you can ablate on the way back. That is true if, of course, your stenosis is not very tight and not very long. So if you are not able to push the burr, the orbital atherectomy burr forwards to do the backward cut, then in aortic lesion you're in trouble. Orbital atherectomy is rotational atherectomy is the way to go in angulated lesions for mainly 2 reasons. One is the orbital atherectomy wire is a 012 wire, so it will give you more bias compared to the 009 wire of the rotational atherectomy, number 1. Number 2 is by virtue of how it cuts, because of its forward cutting mechanism, versus the orbital movement of the orbital atherectomy in angulated lesions. If you are planning to do atherectomy in angulated lesions, I'll tell you rotational atherectomy will be safer. And in stents, if you are going to ablate a stents, rotational atherectomy is a safer way to do, because I have seen some very good US operators, they have actually ablated the stent. Actually, the whole stent has come out with orbital atherectomy. So there's some problem.
So very interesting point said. What is very important to note that the technology has to be used in the proper way. So if we are going to use orbital at a high speed, every time that you orbit, you have to take a puff and see if there's any dissection, because the mechanism different. It moves in a circular way. And if it moves in a circular way, it will find the dissection and it will create a perforation. So in the presence of dissection, do not orbit. That is the dictum, and that is why all the perforations have occurred. So check after every orbital run that you have taken whether there's a dissection or not. You find a dissection, stop. That's your end point. Second, forward cutting and backward cutting mechanisms are both there, which makes that osteal lesions, you can always do a backward cutting, which gives us an advantage. Less incidences of a stuck burr occurring in those situations. Thirdly, when we talk about wire bias is very important, because in rotational atherectomy, we have a forward and backward movement. But in orbital atherectomy, the crown is placed in an eccentric manner. And when it's placed in an eccentric manner, and it's moving centrifugally, it's moving round and round, not forward and backward, the wire bias becomes less. You tend to hit all sides of the wall. So those are very interesting differences. All technology is beautiful. All technology should be used beautifully. Thank you so much for a lovely presentation. One last question, please.
This is then which you use rotatripsy for?
Yeah, that's a good question. I think the rotatripsy is the, if you have a, if you want to ask me about where, now, if an operator is proficient with rotational atherectomy, orbital atherectomy, and IVL, I will say I will probably prefer to use IVL. See, IVL is the safest of the three and the easiest to do. There's no doubt about that. So IVL, I will say, if you have a large vessel 3.5 and above, you have a proximal lesion, easy access, the IVL balloon will go straight, you do a IVL and you can come out. If you have more diffuse angular tortuous lesions where your IVL balloon is not going to take a turn, that is where I would, there are two things you can do. The safer way is to do a rotational atherectomy with a small burr, make a passage, then you take an appropriately sized IVL after imaging and they do a rotatripsy. That is easier to do because I have done, trust me, it is changing a burr, upsizing a burr is not easy, it's tough. And then again, your guide catheter size matters also. So if you've already started with 6 French, you may not be able to upsize to a very big bird. That's another point.
Sir, do you still start with 1.25 or 1.5 in a narrow vessel?
No, see, thing is, what size burr I will use, it does not actually, there are two things I will say here. If you have a very calcified lesion, I would prefer a burr to artery ratio 0.5 to 0.6, no doubt about that. That's what we'll do. However, let me tell you, if you find that you cross with a workhorse wire, and you have difficulty in passing a microcatheter to do the exchange, you either have to screw the microcatheter or you have to use a screwable microcatheter like a Corsair Pro XS or Taunus. You start with a 1.25 mm burr. If your microcatheter goes smooth across, even if it's a tight lesion, if you have a normal wire, your microcatheter has gone smooth, you have exchange for your wire, you do rota with a 1.5, no problem. But if your microcatheter is having problems in going across, you have to screw it in, or then in that case, I will say you took 1.25 or 1.5 will not go, it will just waste money and time.
So, thank you so much. And now very nice presentation. And we'll move to our next presentation. Dr. Preeti's presentation is now working, so we'll have that.
Thank you, and I'm sorry for the initial glitch. Thank you, Vinkars, and I'm going to present this live in box calcified osteal LCX disease.
Can technical team please look at the mic?
So key objectives of these presentations are to highlight the value of plaque preparation technique in performing PCI in severely calcified stenosis, and to discuss tricks of successful and safe PCI in severely calcified stenosis. So here's my patient. He is a 78-year-old gentleman. He is hypertensive with nephropathy. Creatinine is 1.26. He had CABG in year 2008, where the grafts, Lima Y graft was given to D1, PDA, and PLV. And we did his angioplasty to LAD in year 2020. And now he has again come to us in my OPD with a history of chest pain on exertion for 2 to 3 months, modified bruise, stress test positive, and he has normal LV function. So this is how the angiogram looks like. This is a radial angiogram, left radial, because we had to hook Lima in this. So as you can see in this right panel, RAO caudal view, there is a critical ostial LCX stenosis. There is a LAD and a ramus branch. This is the AP cranial view. You can see that the early diagonal ramus is fine. D1 is occluded. The graft has been given to this D1. And the stent in LAD, proximal LAD is perfectly fine. And now this is the LAO caudal view. You can appreciate the critical stenosis in the ostial circ. And it has a good OM branch. And there's no graft to this OM. So this is again an AP caudal view to show that the critical ostial lesion in the circ. This is the RCA, which was diffusely disease calcified. So the grafts were given to PD and PLV. Now this is Lima, which you can see that it is to the D1, PD and PLV and is flowing fine. So this is my patient, chest pain. So now with this, I'll take a pause and we all agree, I think this gentleman needs PCI to LCX because we see that the LAD is okay, the grafts to D1, PD and PLV is fine, and there was no graft to LCX or OM at that particular point of time, and now he's having critical ostial stenosis. As I could draw this lesion, it is looks like a trifurcation lesion. This is the calcified plaque or nodule, whatever you think. Critical ostial stenosis with a good distribution, 2.5 millimeter size branches. So we want to discuss how to deal with this patient. So my idea, I'll just share with you. My idea was that the wiring in this patient is going to be difficult. So my plan was to take a microcatheter and my workhorse wire. If it doesn't track, my idea was to take a polymer jacketed wire. And then plaque preparation, if my IVUS catheter crosses, then image guided, or if it is an uncrossable lesion, rotablation, and then based on imaging, either I use a NC cutting, scoring, or IVL to improve vessel compliance. And stent strategy, I was planning to stent from LM to circ and optimize, and to ensure good anatomical and functional results. I'll take a pause if anyone wants to contribute. So now, this is the live in box. So initial, so this is again a radial procedure. We have taken a 6 and 7 sheath. This is a 7F EBU 3.5 guide catheter for good support. And then I kept a wire in the ramus branch because the initial angle was 90 degree and it was a difficult to cross lesion. This is a Sean blue wire with a micro catheter. And as you can see that the wire could cross the proximal band, but again and again it was going into some kind of side branch. Then that gave me an idea, maybe I am in some channel or some micro channel. So then I had to take a pause, and then in the double mag, we checked that whether we are in the right track or not. So this clearly shows you that you are in the right track, and there is a branch which is coming from the mid-circ, and your wire is getting deflected into that branch. So when I got this idea, then I could maneuver my wire, this was a Xion blue, maneuver my wire into the distal. With some difficulty, it took me approximately 5 to 6 minutes to wire this vessel. And now you can see that the wire is tracking down. And the next step, my fine cross was in the guide catheter. I wanted to see whether I can cross my micro catheter in this. And to my surprise, fine cross with some difficulty could cross this lesion. So I'll just show you. This is the fine cross coming there. There was initial resistance at the proximal segment, and then we could cross it. Then we tried to cross it with the IVUS catheter. But at that particular moment, we could not cross this lesion with the IVUS catheter. So now it is imaging catheter could not cross the lesion, what is the next step we should follow in this patient?
So obviously, if your imaging catheter is not crossing, we have a critical lesion, possibly calcified post-CABG patient, you would think about going in with a rota ablation at this point?
Yeah, so that's what we thought. We changed this wire with the, so whenever we are doing complex procedures, we keep a femoral venous sheath there for the backup, and then at this particular moment, we were just tracking it. So, because my microcatheter could cross in this, then with the help of fine cross, I changed it to rota wire, and this is the rota wire with the difficulty we could cross. And what size burr in this patient? That was also like, the circ is looking like 275 in the mid segment, and fine cross is crossing. So, and there's a difficult calcified lesion there. So if you do it with a 1.25, you have to again upsize the burr. So my idea was maybe because the microcatheter is going, I use a 1.5. If it doesn't cross, then I step down. So that was my idea of choosing a 1.5 burr in this patient.
Which is okay. We agree with the 1.5.
The danger with the 125 is you may get it trapped. Yes. So the calcium is very eccentric there. You can see that. I would straight go with 1.5.
So with the help of microcatheter, we have changed this, and now you see that my burr is stationed there. So the initial step, you just take a pause and just release the tension out of the burr. You have your burr in the left main, and then now you have to burr at an angle into the circ, so your burring should be very gentle. And now you will see that after releasing the tension, I'll just cross this burr into the initial, the proximal circ lesion. And I was at a speed of 170,000 RPM in this patient. So you see that the burr could cross, but there was resistance in the proximal segment. So I was being cautious. I just pulled out my burr, give it a pause, waited for a few seconds, and you can see on the left down panel that there was no hemodynamic change. Like BP was stable, heart rate was stable throughout the burring. It was a short burr, burring time with a time of somewhere around 20 seconds. Then again, we did this burring, rota burring in this patient. This is the, now you can see that the initial movement is easy, but now you are stucking up in the mid segment. So there is a mid segment I was finding resistance, and there was deceleration in the speed of the burr. So then again, the third run we took. Slow and gentle pecking movements. Then again the pause, and then the fourth run. So now here, my only idea was that in the mid segment, there is some calcified nodule, which is not letting my burr go. So again, just try to burr this lesion, and yeah. So now you can see there is a jump in the rota burr. And now after this, we did a polishing run. And then after that, we changed this rota wire with the help of fine cross microcatheter, put a Xion blue in the LCX. And now is the time that after doing rota, we normally have a protocol in our lab that we check it with a balloon expansion. Like then we took a, because we did rota with a 1.5, we took a 2.5 balloon. And before taking this balloon, I had to wire LED, because now you are going to dilate in the left main ostial LCX area. So now after this, I took a BMW wire to wire LED. This is the balloon, you can see the balloon trapping technique to take this microcatheter out, through which we have exchanged our rota wire to Xion blue. Now this is the LED wire, and this also gave me little trouble. You can see that this was getting stuck in the proximal segment where the stent was. And then I checked it in AP cranial view, whether I'm getting stuck in the struts of the stent. So this is how it was behaving in that manner. And now the AP cranial view. So again, we pulled this wire out, just saw the anatomy, and then again, with some difficulty, we could cross this wire into the LED. So this is the LED wire. This is going in the septal branch, and then again. So now we dilated it with 2.5 balloon. We dilated circ and the proximal circ segment. But after doing rota, even the rota, you can see that the balloon, even if I'm keeping it in the left main, the left main is short. The balloon is getting slipped into the proximal LCX segment. So I did 3 dilatation with the NC 2.5 in the proximal circ, but the balloon was getting slipped. At that particular moment, we thought, now let's see imaging. So this was the imaging light. As you can see in the lower panel that there was a calcified eccentric nodule. And then again, you see there's a nodule. So now we are into the mid-circ. Again, the eccentric calcification. Again, you can see from 9 o'clock to 6 o'clock, there is eccentric calcification, but we have a good lumen there. And now as we move forward, this is a relatively healthier vessel. And then there is a dissection in this segment of the circ. And then there is a nodule which is coming from the top, and it is like 180 degree. And the length, you see that this nodule is actually engulfing the proximal circ, ostial circ, and coming up to the left main. So this is all calcified nodule. And at the ostial circ, you will see that the lumen gain is not good. So this is the ostial circ, and then you will see the left main. I had to literally pull my catheter because it was getting stuck there. So this is how the IVUS was. So now what strategy should we opt? We have done rota. We have 1 or 2 planes of dissection. We have nodules coming there. But we have a good lumen gain. Yeah.
So you have 2 to 3 options right here. You have nodular calcium also. This is the point at which that an operator starts thinking that do I need to do a combination, a rotatripsy, or do I do a rota cut? And the operation also gets a orbit regret. That should I have gone in with orbital in the first place? So I would have been able to deal with everything. So orbit regret, rota cut, rotatripsy. You have 3 options right now. What did you do?
With the dissection, IVL is a safer option. If budget is not a problem, IVL is a much safer
And budget
option.
is the question.
And,
so did you go with that?
Exactly as ma'am pointed out, I had 2 IMH, like one at the distal end and one at the segment where the nodule is coming up. Giving an NC high pressure or a cutting balloon might extend this. That was in my mind. Or should I take a stent and then do IVL if I get an under expansion? But I thought maybe I'll give 2 or 3 pulses, let's see how it behaves, and then I'll take my stent. So that was the idea behind. So I chose maybe IVL is a little safer option rather than taking a cutting balloon or a high pressure NC balloon in this patient.
Why didn't you want to take the cutting?
No, I thought I was not willing to do a cutting while we have this IMH in there. So I had taken an IVL balloon in this patient, thinking. Yeah. So you see in the lower panel that we gave, size of the vessel was 3, so we chose a 3 IVL balloon. And we have given 3 pulses at 3 places, at the mid nodule, in the proximal segment, and in the left main area. So after this, after we have done IVL, I have that IVUS image, somehow it is not in here.
So this was the IVL balloon in the proximal, left main proximal circ lesion. It is nicely expanding. There is nothing, no under expansion after we have delivered the pulses. And then we have, because there was an IMH, I had to just downsize my, my landing zone. Now this was into main circ, I had to jail the OM branch to give it a safety margin because this was extending up to the bifurcation point. And I took a 2-5-20 stent in the distal segment, deployed it at 7 atmosphere, just pulled it, deployed it at the nominal pressures, and then I measured the proximal segment. That was accidentally done by my partner because I could see that there was a major dissection there on IVUS, which we did after IVL. So you can see there were many dissection planes, and I wanted to avoid aggressive dye injections. I was telling again and again, don't give aggressive dye, and then we measure, it was like 24 millimeter, and then we took a 3.5-24 stent for this segment, or it was a 324 stent, and then after checking the position, you can see that the proximal segment, now you see that there are some dissection planes, which actually made me a little nervous that day because it was a very aggressive plaque preparation in this patient, even with 3 IVL pulses. And then this is the stent. So now we are checking the stent, and you can see that there's some myocardial staining. The stent was deployed at a nominal pressure, and then we did a pot with a 4-6 into the left main. And I'll show you, this is the last image. And you can see that the proximal segment, you can see that there's a contained perf. I'll show you the IVUS image also. So this was the IVUS image post-stent. So we all want to optimize our results as soon as we see that
technical
the stent
support, our screen has disappeared.
Preeti, your stent in LAD is patent and you have a patent Lima to LAD. Why?
No, not the Lima graft was given to D1, PDA and PLV.
Okay.
It was done way back. And I did angioplasty of this patient in 2020 for LAD.
Okay.
Yeah. So this is, now I wanted to emphasize that you see this is a nicely deployed stent. And then you will reach an area.
The LAD was never grafted in the first place, is it?
What happened?
No.
Sorry?
The LAD was not grafted at all. So a CABG was done for non-LAD lesion?
Yes, way back in 2008.
Okay.
Yeah. So now you can see, now you see that the stent is hanging out there. Never ever try to go and oppose this stent because it is a contained perf. You might have a frank perforation if you try to deploy this stent in that area. So this is one thing which actually made me scared that day. What did you do? It stopped running actually. So you see from the distal, this was the distal branch, and you see that IVUS is coming. We come into the proximal segment, and then the branch is merging, and then this is the stent in the mid-circ. Well-deployed stent because we have done an aggressive plaque preparation here. And then you see, this is the nodule, but we have a good expansion, eccentric, but you have a good lumen gain here. And the lower panel, I did show that the distal was 7, and the ostial circ was 7.1, and the LM was 14 in this patient after doing this stenting. So now here we reach an area which is actually scary to see on IVUS. This is the stent, and now you see this stent is hanging into the artery. This area particularly, these 3-4 millimeters. Now again you come to the area where the stent is deployed properly, and now we'll reach the left main. This is the ostial circ. This is 7.1, ma'am, and then LM is 14. This is LM.
Case is over?
Yes.
Thank you so much. Very interesting case and very adrenaline running case. The only thing is that now we have a big dissection over there, and there's some, you know, the dissection is extending inwards, and you have thrombus over there is what we could see. And there's a portion of the stent behind which there's a lot of thrombus, possibly contained. Yeah, now the question is, over time, all this thrombus gets absorbed. And then we have a
So
malopposition.
when you leave a patient in this situation, your patient is doing well, you have observed them for 48 hours, it is our duty to do their check angios after a month or so. So we have a plan to call
Yes,
this
that's a
patient.
good idea.
Yeah.
So take him back
Plan
and
this
do a
patient,
check.
because
And what was your
sometimes-
antiplatelet regimen or anticoagulation regimen in this
Because
patient?
he's an 80-year-old male, he was on clopidogrel and aspirin. No troponin rise, so I kept him on, and he was loaded previously with the clopidogrel. So clopidogrel and aspirin in this patient.
Did you, you know, sometimes I put such patients on an additional NOAC in spite of the fact that the age, because there's a thrombus sitting over there. We don't know. But I think important is that you salvage the
It's
patient.
more of contained perf.
Yeah.
I'm more worried for that. And interestingly, we had asked our the doctor on duty to look for pericardial effusion, and we were fools. We didn't realize it is a post-CABG patient. You don't
There
get
won't be any pericardial effusion in such a
So
patient.
he's like, every hour he's doing echo and he's telling me there is no pericardial effusion. So then I realized after 2 hours that what foolish thing I have asked him to do.
That's
He's
so.
not going to have pericardial effusion.
Thank you so much. In the interest of time, we'll move to our next presentation.
Thank you.
And we'd like to welcome Dr. Ajit Mulasari to present on purpose-built stents for left main bifurcation PCI addressing distal vessel mismatch issue.
So thank you once again. And can I have my slide? So clearly, we need a 3.5 stent plus in the circumflex. We need a 4.5 maybe in the left main. So that's the plan in my head as I start doing this case. The next thing what I do is I go into the balloon, predilate the LAD and do the left main LAD and the left main circ with two balloons, and then we stent into the circumflex with a minimum protrusion. This is a DK crush, so we put a minimal protrusion to the distal left main, and that's very important that you should not protrude too much in a DK crush. You have a balloon in the LAD, as you can see very clearly. The balloon is sitting here, so you can crush that lesion there. You crush it using a 3.5 NC Trek, and then you recross proximally with the hydrophilic wire, and we dilate with a 1.5 balloon, and then post-dilate with a 3.012 and a left main LAD with a 3.5 NC Trek. We do the first kissing, and then we stent the left main to the LAD with a 3.5 into 2 synergies. The IVUS, as you saw, had an LAD at 3, the distal stent was patent, and we know the synergy will go up to 3.5, will go up to 4.5 for sure, and 4.6 is what you have. And then you do the port, and followed by the balloon dilatation, you do the port, you finish the port, you circ rewire, you do circ dilatation again, you do the LAD dilatation, the second kiss, and then you finally finish with the last port. So this is a sequence of DK crush which you should do stepwise in every patient who has a DK crush. Now the question is, we did all this. This is the diameters we got post-procedure, and you have a pullback from both IVUS, from the circumflex and LAD, looking good. I don't think there's a problem. You got a left main diameter, which is a distal stent diameter of 3.8, the left main at 4.75 from the circ, and the mean stent area is a left main 15, LAD is 10, circumflex is 9, and the POC is 10. Excellent date, excellent result so why do we need anything further? The question is that you were lucky that you had a 3.5 circ, a 3.0 LAD, and a 4.7 left main. Say you had a 6 left main, what would you do? That's where the issue starts, when you have a lesion which is 2. And that is where things will change, and that is where you need better stents for the whole thing. If you look at the Excel data, acute stent deformation occurred in 6.55% of cases. And if you had a stent deformation, patients did badly. You had a double MACE if you had stent deformation. And when does stent deformation occur? When you overdilate stents, which cannot be dilated. When you shorten stents, when you overdilate. And when you are trying to push the stent up or push the stent in, and you deform the proximal part of the stent with the longitudinal stent deformation. So these are the 3 areas where you need to be careful when you're doing left main stenting. So clearly we need to not have stent deformation from the Excel data. You will get double bad outcomes in terms of MACE. Now this is the new kid on the block, and just want to know, none of us, I have not used it, but some of people in India have used it. But what I want to ask you to look at very carefully is the design. It's got, first thing, a strong radial strength related to 2 issues. One is a 12-peak design with short struts. This makes the radial strength very, very good. There are 4 connectors on the proximal segment. Again, makes radial strength very, very good. There's a 4 micromillimeter abluminal bioabsorbable polymer, which makes the drug elution characteristics pretty good. And there is 3 connectors throughout the body. 4 connectors proximal, 3 connectors distal, 12-peak design with a 4 micromillimeter abluminal bioabsorbable polymer. So it gives you 2 advantages: good axial because of the struts, and good radial because of the connectors. And it's extremely good when you're dealing with left main and proximal LAD. The other big advantage of this is this. You saw the synergy being used in the last case. I had a push of a 3.5, I could push it to 4.25, a little bit of push, I can get 4.5. With a Megatron, a 3.5 easily goes to 5, and with some push, I can get it to 6. So if I have a really roomy left main, I can't put the synergy, because the synergy will go only up to 5. And if you try to push it up to 6, you're going to break the strut, and you're going to get a deformation, which is a problem. So this stent gives you that advantage of additional connectors in the proximal segments, which gives you the strength both radially and in axial length, in axial strength. The other thing, the stent pattern is maintained. Many times when you open the stent with high pressure or high dilatation, the stent looks deformed on the IVUS or the OCT. Here the design remains exactly the same because you can see the 9-peak design on a prototype on the top and a 12-peak design on the bottom, and the same diameters, 3.5 and a 5, and you can see how the synergy megatron performs in terms of the pictures. Very, very clean, no deformity in the pattern, no tissue prolapse. And this is something, when you make the stent roomier, the struts move aside, you'll get tissue prolapse. That doesn't happen here. So clearly the 12-peak design gives you a much better strength to avoid prolapse. So these are the various side branch expansion criteria. We can see the access which is there with all of these are good stents which are currently available. And I think that this is the great part of these new stents, that you're getting access, strength, axial, radial, and strut design maintained through the artery. I think it's a purpose-built stent for the left main, and this is what you're going to get now with the best-in-class axial and radial strength, uniform scaffolding, good over-expansion. We can get up to 6 very quickly, and I'm not saying this is the only stent. We've got other great stents, the Sierra in the market, we've got the Nagomi in the market. All of them give you this thing. And most importantly, it has a platinum chromium on top of it, so I can see it in the cath lab very, very easily to prevent longitudinal deformation. Your guide will get sucked in when you're doing these kissings in DK Crush, and you will be very, very careful with your guide, because the guide is going to hit the stent and you're going to get a longitudinal deformation. So I think that to conclude, what I would like to say is that here we have a great stent which gives you a strength, a design, and increased expansion over ability to give you a great. Finally, we need to also understand the trackability of these stents. These stents are good at bends. They can have because of their bending, they can, you need to be very, very clear that you don't lose acute lumen loss, because some of these stents, when you track around, you can lose lumen when you because of recoil. I think that this, again, I've told you, and I think that this is a good delivery system. I've used it in very tortuous radial arteries with no backup, and these stents go very, very nicely around these bends. So I think this is another interesting innovation of laser cut hypotubes, which makes the stent very, very conformable and flexible with pushability. So I'd like to conclude by this slide by saying that we are getting these stents which are trackable, which are optimal, which are strong, both radially and axially, and the deformation of the stents in the left main, which is in Excel showed the outcome differences of MACE by double will come down with these new left main specific purpose-built stents. Thank you very much.
Thank you very much, Dr. Ajit. And that is an amazing presentation. And it's so important when I was looking at the presentation that about a year and a half ago, we didn't have Nagomi, we didn't have Megatron, we didn't have a Sierra, and now we have all of this equipment in our hand, which makes left main bifurcation and vessel mismatch size PCI so much more better. Thank you so much. And in the interest of time, we'll move to our next presentation. This is from Women as One. It's a virtual presentation. And we have Dr. Erica Osikweri speaking to us. Erica, can you hear us? Erica, can you hear us? We can't hear you. Technical support?
No.
So Erica Sakeri is Head of Engagement, Women as One. So as we try to collaborate with Women as One, so Erica is with us to help us in this process. Erica?
Can you hear me?
Yes, yes, yes.
Oh, good. Okay, great. Hi, everyone. Thank you so much for allowing me to join you for the 16th Annual Women in Cardiac Care Conference. I really appreciate it. I'm going to share my slides. Hopefully you can see them. So technical difficulties are always the trickiest part. I'm going to talk to you all about women in cardiology, the past, present, and future. And I appreciate, again, the opportunity to chat. WinCars, the Women Have One have been partners for quite a while. And it's really an exciting opportunity to join you all for my morning and your evening. And I was able to listen to the cases, and it just sounds like a fantastic event. So I'm going to start off by talking about a little bit of contemporary data to talk about the past and the present, and then end with some what we hope are some future solutions. I will say in the beginning, the data that we have as far as representation and understanding the picture of women in cardiology is really limited, unfortunately, to US and European data. So one call to action I would encourage all of us, and Women as One would love to work on, is how do we get this data globally? How do we understand the picture of women in cardiology around the world, in Asia, in Africa, in Latin America, where studies have been lacking? I do think there is a gap in research, and one that I think needs to be solved. So would love to talk afterwards on how we can partner to get this data globally. But for today's purposes, I'm going to start with this study that was just released in JAMA Cardiology in January of 2024 to talk about the representation of women in cardiology in the United States. And for the past few decades, women in cardiology in the workforce has been pretty stagnant in the United States, with about 20% of all practicing women cardiologists represented. But we can see, if we're looking at women trainees in the United States from 2008 to 2022, there have been some strides in the overall representation of cardiovascular disease, primarily driven by more women trainees in interventional cardiology and electrophysiology. Similarly, representation of women in cardiology in Europe tells a slightly better but consistent picture, with about 35% of EU women in cardiology represented, primarily driven by the UK, Germany, and Spain, with low representation in Germany and France. But when we're taking a look at leadership positions in both Europe and the United States, there's much work to be done. In fact, if you take a look at the study of women in cardiology by department leadership in Europe, there are several countries where there are no women represented in leadership departments throughout all of Germany and Greece, just to name a few. And similarly, if we look at academic faculty rankings in the United States, it tells a similar picture, where when you go up the ladder to full professorship at both public and private institutions in the United States, you're under 20% of full professors in public institutions and closer to 10% of women as full professors in private institutions. And even more alarming, if you're looking at women cardiology and procedural leadership by both the Watchman and PCI, we're looking at closer to 3% of procedures by gender, with women as leading procedural leadership. And finally, if we're looking at women in cardiology from a clinical trial leadership perspective, sorry, I'm going to move my screen here. 50% of leadership committees had no female representation. 42% of trials had no women investigators, and only 9% of trial publication had women in first authorship position. And lastly, and I think most importantly, if you're looking at the entire culture of cardiology as a whole, we can see that whether it's components, prevalences, or consequences, there remains a culture challenge, not only for women, but for men too, related to cardiology. And this study was taking a look at a global understanding in JAC in 2021 to understand that women have faced more emotional harassment, sexual harassment, and discrimination. There was a higher prevalence of harassment for men compared to their male counterparts. And the consequences, 79% reported adverse effects on professional activities with colleagues and as well as patients. So not only are we seeing a hostile work environment, which is not a good thing overall, but it is having an adverse effect on our patients too. So I think if we're looking at our past and currently our present too, there's much work to be done. And so that's why we at Women as One are founded. So Women as One was founded in 2019 by Dr. Roxana Moran and Dr. Marie-Claude Maurice 2 internationally recognized leaders in cardiovascular care and research. And our mission is to promote talent in medicine by offering women physicians unique professional opportunities. And by doing this, we aim to build a more inclusive, diverse, and just workforce in medicine. How do we do that? Well, our approach is kind of three-pronged. We want to amplify women by highlighting their collective work and voices around the world. We want to fortify them through educational and awards programs. And finally, we want to unify by working with like-minded organizations like WinCars. How can we all come together to change the status quo that we just saw to make a better workforce for all, and more important, for all of us to thrive? So our work to do that is in three buckets. We're into threes here at Women as One. Our talent directory is our professional network and global data source where we unlock exclusive professional opportunities for women cardiologists. We have programs, Climb, the Escalator Awards, and Rise. Climb is our virtual program, the Escalator Awards is our funded program, and Rise is our in-person learning opportunity. And I'll speak to each of these more in a moment. And finally, Equity in Action, taking known barriers for why women do not enter the field of cardiology, such as radiation safety, parental leave, or professional advancement. How do we create resources and publications to combat these known barriers and to change the status quo? Our talent directory is a global community of 2,400 plus women physicians, wherein women physicians join the talent directory to unlock professional learning opportunities, and organizations come to us with professional opportunities to match qualified women to these professional development opportunities. To date, we have over 2,400 women cardiologists in the talent directory, representing 100 countries and 15 subspecialties. And while we've seen a great diversity in a subspecialty and regional perspective, I do have a call to action for all of us today in the room. Right now, we have 35 registrants from India, and I would encourage all of you to join us at Women as One by signing up in the talent directory and visiting our website at womenasone.org. It is free to join, and we'd love to get to know more about you and for you to get to know more about us at Women as One. In addition, in our talent directory, each person has the opportunity to fill out a research profile so that we can know what topics you're interested in research, what types of research that you have completed, and whether or not you have or are interested in clinical trial leadership. And why is that important? Well, if we look at a consecutive review of NIH and industry-funded trials from 2010 to 2019, we can see that there has been a slight increase of female clinical principal investigators. But more importantly, we see that when women are leading clinical or are PIs in clinical trials, they are able to recruit more female patients in trial studies. So if we want our trials to match a diverse population, we need our trial leadership to do the same. And as such, at Women as One, we are developing a set of resources through the Women as One Clinical Trial Innovation Group to find and increase and enhance the participation of women in cardiovascular clinical research, whether that is training up qualified women investigators, funding and promoting women researchers, and developing best practices for diverse clinical trials. We are working behind the scenes and will be excited to share these results this year in 2024 and how we can all make our trials more diverse and more representative of our patients at large. Additionally, I want to end with a little bit more detail on each of our programs. Our 2024 Escalator Awards are our grant funding mechanism, wherein this year we are focusing primarily on mentorship. We will pair a mentee with a mentor, and the mentee and mentored will develop a 12-month project based on mentorship for the year. Excitingly, we have our Climb Clinical Program, which is our 6-month virtual training program where women are in a small cohort and learn from leading experts in both didactic and case-based learnings once a month on topics this year in heart failure, prevention, atrial fibrillation, and structural imaging. It is free to participate in Climb, but you must be a member of the talent directory to do so, and applications will open this April. Again, another reason to join the talent directory if you are not already involved. And finally, I want to encourage all of you to join us at Rise at ESC 2024. This year, we are so thrilled to be partnering with ESC and have an in-person program the day before ESC at the Excel Center in London, England. As I mentioned earlier in our previous slides, there is, I think, a need to have personalized leadership development for women cardiologists. And we're very excited to bring together a full day of programming related to how we can all develop better as leaders. Applications or registration will open next month. And so we would encourage you all to learn about the program more at rise.womenasone.org. And we hope to see you all in London if you will be at ESC. So in conclusion, if we're thinking about the future, we at Women as One feel the future is bright for women in cardiology. And we encourage all of you to join us to help make this future brighter. Feel free to contact me at any time, and my email is Erica with a K at womenasone.org. I'm happy to answer any questions you may have. Please join our website at www.womenasone.org to learn about everything I chatted about today, as well as to join our talent directory. And also feel free to follow us on any social media platforms such as Twitter/X, LinkedIn, or Facebook on @WomenAsOne. I want to thank you for allowing me to join this fantastic group, and I wish you all the best of luck in your conference this weekend. And thank you for the opportunity to allow me to share more about Women as One and the past and present and hopeful future of women in cardiology around the world.
Thank you, Erica. So
Thank
we
you.
hope to increase the participation of Indian women in Women as One. And we hope to partner with you more with clinical data, registries, and so forth. Thank you once again.
Yes, wonderful. Thank you all. Have a lovely meeting.
Okay, coming on to the last session of today, Meet the Trialists. I invite upon Dr. Josna, Dr. Sujata, Dr. Asha, and Dr. Cicely to please come onto the stage and chair the session. I think these are online sessions. The IT team ready? Ma'am, Dr. Ankur Kalra is not here. The second Krishna Raj Rathod.
Thank you. Thank you. I'll just share my screen.
Who's speaking?
Can you see that okay?
We are able to see the slides.
Thank you. So thank you very much for the opportunity to today. My name's Dr. Krishna Rathod. I'm a interventional cardiologist consultant at Barts Hospital in London and a senior clinical lecturer University of London. It's a great honour to be able to present today our research done at Barts Hospital and part of the Pan-London Heart Attack Group, and I'll be talking about the association of socioeconomic status with procedural management and mortality after PCI. And this is an observational study from the Pan-London PCI Group of no relevant financial relationships. So just a bit of background. So lower socioeconomic status is associated with the development of an increased mortality from coronary artery disease. And this excess risk may be due to combination of more adverse cardiovascular risk factors, inequalities in access to cardiovascular investigations, as well as longer waiting times for cardiac revascularization. In addition, it's been associated with lower use of secondary drug prevention as well. There have been studies performed already, and data from a Denmark study found that even in a country which has universal tax-financed health systems, patients with lower socioeconomic status undergoing PCI had worse outcomes than those with more resources. These were replicated in findings from a Canadian study, but other studies have also suggested that lower socioeconomic status patients have greater comorbidities, longer reperfusion times, resulting in comparable outcomes when these are accounted for. So what we wanted to do is to investigate whether socioeconomic status influence procedural outcomes and long-term all-cause mortality after PCI in a large metropolitan city of London, which serves a diverse population of 10 million people with a mixed social background. Our methods included a prospective observational study from the Pan-London PCI cohort, and I'll describe this in a bit more detail in a second. It had patients from 2005 to 2015 at 8 tertiary cardiac centres across London in the UK. Outcome was assessed by all-cause mortality via the UK Office of National Statistics with a median follow-up of 4.8 years. So just to talk about our Pan-London group, so we have 8 primary PCI centres in London, including Barts Health, NHS Trust, which is where I work at, the Royal Free Hospital, the Brompton and Harefield, St George's Hospital, Imperial College, Guy's and St Thomas's, and King's College. And these serve the 10 million people in around London. So how was the study executed? Well, the socioeconomic status of each patient was derived from the 2010 version of the English Index of Multiple Deprivation, or the IMD, using the residential postcode or zip code in the US. The IMD divides England into over 32,000 small geographical areas, which contain about 1,500 residents who are assigned a score of 7 domains, according to the information obtained from the 2010 National Census. These domains include health and disability, income, education training, employment, housing servicing, crime, and living environment. Each of these domains are weighted and then pooled to provide a single measure of deprivation for each geographical area. Patients were then divided in the study into quintiles of each IMD score. So quintile 1 in our study was the least deprived, and quintile 5 was the most deprived for the analysis. So what did we find? Well, we had 123,780 patients in the whole study who had PCI in the 10-year period. And as you can see, from quintile 1 to quintile 5, the group had more ACS in the most deprived group compared to the least deprived group as quintile 1. If you now look at some of the baseline characteristics, and I apologize for the busyness of this slide, but there were the patients in terms of age were younger in quintile 5 compared to quintile 1. We had fewer Caucasian patients in quintile 5 compared to quintile 1. We had less hypercholesterolemia, but we had higher incidence of diabetes, hypertension, smoking, renal failure, poor LV function in quintile 5. There were fewer incidences of previous bypass and PCI in the most deprived group, quintile 5, compared to quintile 1. In terms of the procedural characteristics, what we found was that there were higher rates of ACS, mainly non-aspiration myocardial infarction in quintile 5, which is the most deprived group compared to the least deprived group in quintile 1. We had more radio procedures carried out in the quintile 5 group. We had less use of GP2B3A inhibitor in quintile 5. Fewer complex cases of fewer CTO procedures done in the most deprived group. And in terms of multivessel PCI and imaging use, this was less done in the 5th quintile group compared to the least deprived group, which is quintile 1. In terms of procedural outcomes, we had higher incidence of major adverse cardiac event in terms of death in the quintile 5 group compared to quintile 1, but less bleeding. So looking at this over time, we had the proportion of patients in the most deprived socioeconomic quintile increased during the 11-year period, with an increase in both stable patients undergoing PCI in quintile 5, as well as acute coronary syndrome, as I already mentioned. So this is the most important slide in the talk. Essentially, the Kaplan-Meier curve, which is a primary endpoint, demonstrated that rates of all-cause mortality, long-term mortality, progressively increase across quintiles in the IMD score, with patients in quintile 5 showing significantly higher long-term mortality rates compared to quintile 1. We did a landmark analysis, and what we found is in the first 30 days, this wasn't significantly different, suggesting that it's not a procedural issue, it's not access to the PCI, it's what happens afterwards and their baseline demographics. We did an adjustment for all the covariates, so the factors that I mentioned in terms of differences from the baseline demographics. We put this into a model and did multiple adjustments for confounding variables, and we found that the hazard ratio for death increased compared to the age-adjusted hazard for quintile 5 compared to quintile 1, and this was 1.13 in terms of hazard ratio. We also found that the hazard ratio for death increased in a linear trend for each decreasing quintile of socioeconomic status. Finally, we also used a propensity match scoring system. So the IMD was associated with long-term mortality following inclusion of a propensity match score in the proportional hazard model as a covariate with a hazard ratio of 1.15. So the strengths of the study include patients from 8 different centres in a large metropolitan city of London with a diverse ethnic and social makeup. It included patients with previous myocardial infarction, bypass, and other comorbidities which will be often left out in randomised trials, and this was a true representation of a real-world day-to-day clinical practice. Mortality tracking in England is particularly robust because it's using the UK Office of National Statistics data. And the multivariate analyses highlight the quality of the data with well-recognized predictors of mortality associated with adverse outcome in our dataset. We do have some limitations, obviously. This is a registry-based study, so there are limitations of that. However, we did do propensity matching and multivariate analysis. There is possibility there's underreporting of complications, and we only had all-cause mortality and not cardiac mortality. In addition, measuring socioeconomic status is very complex. While it's accepted as a robust measure of socioeconomic status, the English IMD has several limitations which arise from a methodology of how it's used. In particular, the score is assigned based on defined geographical area rather than on individual subjects' characteristics. Inevitably, however, individuals who live in the same area will not experience the same level of deprivation. Furthermore, IMD scores are not a linear measure of deprivation, nor do they incorporate information on duration of residence. We could not therefore assess the contribution of deprivation exposure time to mortality. Nevertheless, the IMD score is the most effective current means of measuring deprivation in England. So in conclusion, this is the largest study to date looking at socioeconomic status and outcome with over 120,000 23,000 patients undergoing PCI for STEMI and STEMI and stable angina. Socioeconomic status is an independent predictor of adverse cardiac clinical events, persistent after adjusting for baseline characteristics. And attention to reduce cardiovascular risk factor and improve primary prevention in lower socioeconomic status is required. I'd like to end by thanking our team at Barts Hospital. This is a picture of Barts Hospital and our square. We have a lovely fountain in the middle. I just thought I'd show you that. In addition, I'd like to appreciate all the members of the Pan London group. This work has been put together by an excellent group of consultants, registrars, nurses, and teams across London, and it would not be possible without having all of them on board. I'd like to thank you very much, and I'll take any questions. Thank you.
Thank you very much, and congratulations on a very well done, enormous study. It was light on
So once you get to the hospital or get to your general practitioner, everyone gets the same amount of treatment. And equally, even if you approach someone privately, the amount of care you get is exactly the same. It's only that you get seen a little bit quicker just because of the limitations of the NHS. So in terms of answering your question, I think we've already started changing the way we do things. So we have that do social services, social prescribing, in order to make sure that patients who do not know about the opportunities available and managing health have that available. General practitioners have more of an education program, so smoking cessation, adherence to medication, healthy diet, that kind of thing. So education aspects have been rolled out already. But there's a lot more to do. This data, although it's slightly older, there's still a huge amount of work that needs to be done in order to improve that outcome. And it'll be interesting to repeat this study in about 5 to 10 years to see if what we've done has made any difference.
Do you have any community-based rehabilitation programs available for these PCI patients, bypass patients? Do you have any community-based rehabilitations?
We do, yeah. So every patient who undergoes PCI or a bypass, whether that's stable, STEMI, or NSTEMI, are offered cardiac rehabilitation. Most of it happens via the hospital, but there are community-based rehab as well. I think the issue that we're finding is patients don't always attend these. And that, again, is related to lack of probably education and involvement of the patients to talk about health because they have other priorities. So even though the opportunities are there, they're not always taken up. And that's part of the education program we need to work on.
Thank you.
Thank you, Sam. That was a great presentation. We now move on to the next topic by Dr. Saurav Chatterjee. The topic is artificial.
Hear you and we are seeing your slides. Your slides are in the normal mode. If you can go to slideshow, it'll be great.
Absolutely. Thank you so much. So thank you so much for the organizers of Women Cards 2024 as well as the audience for showing up. A very good afternoon, evening to you. And it's morning in New York where I'm based out of. But I look forward to the opportunity of presenting our study on behalf of my co-authors without whom none of this would have been possible. Just diving in, I do not have just relevant to this talk. However, I knows that while this was a breaker, the concept of the study is very much in the preliminary stages of conceptual framework, and I'll delve more into it as I go on. And that to me actually offers a little bit more of a flexibility and opportunity to make this study design even more useful and relevant to the clinical practice. Into it as the talk goes. For our background, stent under expansion is a well-known reason for restenosis and stent thrombosis. There has been a strong association based on previous data on largely superficial calcium, but also thickness, and their association with stent thrombosis and restenosis. Intravascular ultrasound, both in the form of an IVUS and OCT, can assess extent of vessel wall calcification, albeit to different degrees, but IVUS, because of its prevalence, because of its availability, and because of its because it does not require any contrast to be used, may actually have a little bit of an edge for usage compared to OCT even at this time, although obviously is still evolving. And then IVUS unfortunately also comes with the challenges of a manual and automated pullback, different varieties and degrees of resolution and heterogeneous quality as used in the real world population. So some of my co-authors actually have been associated with a prior study which identified features on intravascular ultrasound associated with suboptimal stent expansion and subsequent restenosis, most readily of which were strongly associated with calcium greater than 270 degrees of an arc, presence of 360 degrees entire circumferential calcium, presence of a calcified nodule and vessel diameter of less than 3.5 millimeters. And during our preliminary analyses, we found that all of these features were amenable to automated interpretation. So that brings us to our specific study, which we have some aims using supervised learning, which is essentially a learning which we feed the system certain data. What we find, it analyzes things going forward. And then there are potential aspirations that we have using unsupervised learning, which is another machine learning technique, which essentially extracts features hitherto not known or unknown. So using supervised learning, our hope would be by an automate measure of arc of calcium on a vessel wall detected using a reasonable doses, and then subsequently to build an AI-based automated IVUS-derived calcium score to identify and potentially be able to address suboptimal stent expansion, even using a pre-intervention IVUS run. And then using unsupervised learning, which as a researcher is of even greater interest and would be to identify possibly new which could be associated with stent under expansion, which had hitherto been unknown using prior studies and literature reviews of the same. And then translating into clinical practice, eventually to be able to match the optimal tool needed for achieving improved stent expansion. By optimal, I mean, obviously with calcium modification, there comes certain potentials. There are different tools available already and some in the making. There are potential for risks associated with almost all of them. And, our hope would be to kind of match the best tool with the best risk-benefit analysis equation once this research study is completely mature. Our planned pilot study has like standard steps. We have to acquire image data, which has to be reasonably good from IVUS core labs. Annotate is already in process. We have to prepare data for training, which would be done by machine learning engineers from Dyad Inc. based out of Boston. And then we would be feeding data into a convoluted neural network model for. I'm not a statistician, so you'll actually have to ask my Dyad colleagues to know exactly with that. And then finally, we'll derive a final model to be used for inference on new data, which would potentially be the validation data set, but even more to trial it on a large scale real world basis. But I'll talk more about that. This is IVUS image run from one of my patients obtained with consent. So essentially, this is the estimating the arc of calcium, which is pretty straightforward. We use the standard formula theta equals length of the arc of calcium divided by the radius from the center, and the degrees of calcification obtained in radians, which is an easy transformation into degrees. Our anticipated results would be that we would be able to compare our automated if there is an issue, all of whom are board certified interventional cardiologists. If it falls short, then we do have safety checks in place where we can retrain the classifiers. And a couple of limitations which I would like to bring to highlight at this point is that obviously because of the heterogeneity of the real world and quality of IVUS images, it would be dependent on obtaining a large variety of these to be able to replicate real world usage. And then the other thing obviously is that cath labs are busy. There is potentially different things going on at the same time, and we do not know if implementing such a modality may interrupt or cause a significant time investment or workflow interruption. However, I would like to show some of our preliminary research using OCT, which essentially makes us hope that this interruption would be at best minimal, at most worth it in terms of efficiency. So I would take an opportunity to run our OCT arm of our study, which essentially the Dyad team has already developed cloud, which is FDA approved at this point, where you essentially take an OCT, upload the run using standard DICOM or whatever images that are compatible with the software, cloud-based and HIPAA compliant. And then this is essentially the OCT run, which the software is interpreting and outlining, and any operator can essentially use to modify anything that the computer is generating on its own. And then it identifies the vessel lumen, identifies the calcified nodules, and then essentially it will come up with numbers as you see. on the right side, which would be, sorry for the font size, but you will soon see what the automated results kind of show. As you look to the right side of the screen, you can see it would essentially show all the information that would be needed to get the component of the calcium score that we hope to obtain with our analysis of the IVUS images. So I would like to emphasize that our study is original. We're trying to use an established imaging mechanism and a novel methods to generate a unique tool which might be clinically useful and efficient. We have collaborators with specific expertise. There is existing tools and established methods which indicate a reasonable probability of successful implementation. And obviously, this is clinically relevant because suboptimal stent expansion and implantation increases risk of stent thrombosis, restenosis, and all the other things that could potentially go wrong with stent implantation. And then on the translational side of things, I would also like to point out that there is an opportunity to identify novel risk factors and optimal tools for remedial measures with a pre-intervention IVUS using our tool as it develops. And thank you for your time and attention, and I would love to take any questions at this time. Thanks.
Thank you, sir. And it was a great trial. Actually, the artificial
Presentation. Thank you so much.
My pleasure. Thank you. Thank you.
We now move on to the next presentation by Dr. Scotland. It is leaflet excision.